on stage. We are honored to welcome Dr. Ramalingappa sir, a distinguished professor and unit chief at KIMS Hubli and director of Shushruta Multi-Specialty Hospital Hubli. He is a former dean of KIMS Hubli. Dr. Ramalingappa sir is renowned for his groundbreaking invention of transvaginal clamp for PPH management. With over 20 research publications and numerous awards at state and national conferences, his contribution to medicine are truly remarkable. Let's warmly welcome Dr. Ramalingappa sir.
Beyond his professional excellence, he is a very good sports person and health enthusiast. Let's extend warm welcome to Dr. Guru Prasad sir. Sir, over to you.
Yeah, thank you for a wonderful introduction. Though I told Prabha that you can give it to somebody else, but she told that I only have to talk. So I had to do a lot of homework because of late I don't do much of anesthesia. I do more of critical care. But the safety limits have definitely improved after I got into critical care, and she is given due respect to anesthetist to become the opening batsman, because once I induce anesthesia you can start your cases, and at the same time when I induce anesthesia, please don't sleep. Okay. It's a very nice topic, safe anesthesia practices for gynecological emergencies and endoscopic surgery. Yeah, the outline of my talk will be to know the physiological effects of pneumoperitoneum, concerns in histoscopic procedures, pre and post-op considerations, current protocols and emerging anesthesia techniques, safety optimization strategies and conclusions. My disclaimer is whatever I am talking on regional anesthesia is based on all the publications which are there in the internet and which have been published in index journal. But at the end of the talk, I'll tell my preference of anesthesia. So, definitely laparoscopic surgery has revolutionized surgical practices. So, benefits include reduced morbidity, early recovery and less post-operative pain. Specific physiological changes related to pneumoperitoneum and patient positioning must be addressed, and safe practices are essential for an optimal patient outcome. So what do you mean by safe anesthesia? So it's on delivering anesthesia while minimizing risk and following evidence-based guidelines. So this involves selecting appropriate anesthesia, ensuring equipment safety and possessing the expertise to manage complications. So if you are not sure about what you are doing, please don't venture into it. Okay, so key strategies for safe anesthesia is education. Basically, I have to be trained in a particular specialty to go ahead with that. Though there is a learning curve, but you should get trained in an ideal place and then start the practices. So, as laparoscopy is an advanced procedure, so is the anesthesia involved in it. So, a good anesthesia machine or what we call as a workstation is a must for good safe anesthesia for laparoscopy. Then the type of anesthesia again depends on what type of procedure is being done and what are the comorbidities the patient is having, and finally we can actually monitor the awareness using bispectral index monitors. So just on the history. So the evolution of laparoscopic surgery required parallel advances in anesthesia. Leave about laparoscopic surgery. If somebody is undergoing a heart transplant, it has been because there are advances in anesthesia and post-op care, that is critical care. So it is all parallel. It can't be that cardiac transplant is done and there is no good post-op care. So there should be parallel advances in both the surgical technique as well as the anesthesia technique. So the adoption of general anesthesia marked the crucial turning point, because in 1912 Dr. Jacobius performed his first laparoscopic procedure under local anesthesia, because that time the facilities were not there. And then as the time went in 1930s, advanced field because of the advances in anesthesia, so the surgeries also became more complex and they could do advanced surgeries. And this is a bit of history about anesthetic evolution. That is Dr. Rolf Palmer's introduced general anesthesia in laparoscopy, okay, in Paris. So he pioneered work, established fundamental principles of patient positioning and monitoring that continue to influence the modern practice. So they started with epidural anesthesia in 1970s, then they moved to spinal, then they used combined spinal epidural, then ultrasound guided nerve blocks for good post-op analgesia and intra-op analgesia, and now the digital monitoring systems have improved of late. So what is actually balanced anesthesia? So it is a combination of three. The patient should be amnesic or hypnotic. You should give good anesthesia, and what is more important is good muscle relaxation so that you get good space for to work. So what are the impacts of minimal invasive surgery? So if you have to do a minimal invasive surgery, the first basic thing is you have to create a pneumoperitoneum. But by creating a pneumoperitoneum, it impacts both the cardiovascular and respiratory system, and the CO2 gas which you give causes hypercarbia. Then to move the bowel away from your point of interest, so you have to use different procedures like Trendelenburg, reverse Trendelenburg positions, and Trendelenburg will definitely displace the will change the pulmonary compliance. So what are the cardiovascular effects? Once the pneumoperitoneum is caused, the CO2 insufflation increases the heart rate and blood pressure, while elevated abdominal pressure affects the cardiac function. Basically, the venous return comes down because the major capacitance vessels are in both the lower limb. Because your intra-abdominal pressure goes up, so almost about 500 to 800 ml of blood stays back in the leg, and there is a decreased venous return, that is a decreased preload. On the other side, there is increased vascular resistance, which increases the afterload. So these two combinations and stress response, they modify the cardiovascular effects, cardiac function. Similarly, head low, which is caused by during pneumoperitoneum, causes reduction in the lung capacity, decreases the lung compliance, it affects the gas exchange, and high airway pressures are noted, and there are increased chances of CO2 retention if the patient's minute ventilation is not maintained. Okay. Then there are neuroendocrinal changes like the peritoneal stretching triggering increased stress hormone release, including cortisol and epinephrine. This activates the renin-angiotensin system, affecting the blood pressure and fluid regulation. And there are regional circulatory changes, like as I said, because the intra-abdominal pressure increases, the portal vein blood flow drops by 50%, the kidney perfusion comes down, and the urine output decreases, gut circulation diminishes. But remember, when the pneumoperitoneum is removed, everything, the normal flow is returns. So I tried to search publications or articles on whether they had done acid-base studies intraoperatively, and I found a few, and it says that the commonest acid-base change you see is a respiratory acidosis. That is, you use carbon dioxide, the carbon dioxide gets absorbed through the peritoneum into the blood vessels, and if initially there is a sudden rise of PaCO2, that is arterial CO2, and that has to be maintained with adequate ventilation. Okay, and it also causes reversible venous stasis. So the circulation in the lower limbs comes down slow, and there are more chances of pulmonary thromboembolism. Okay, and that's what if you have to maintain the milieu, they say that there should be lower pneumoperitoneum pressures. So this is when the surgeon and anesthetist keep fighting for. So what does basically a good pre-operative assessment is necessary. You have to have take a proper history and physical examination, and look for comorbidities, whether it is cardiac or respiratory or renal. Okay, and then we should have a multidisciplinary approach. So once the pneumoperitoneum is done, the airway pressure rises by almost 30 to 50%, the CVP increases, and the FRC, that is the functional residual capacity, comes down. And whenever you do a head low, because the diaphragm is pushed down, the lung gets pushed down, and properly placed endotracheal tube in supine can become endobronchial. So that you have to always, if there is a change in peak inspiratory pressure, after there is a head low, please we have to auscultate and see whether both the sides of the lungs are inflating or not. That is one. Second thing, the bevel of the endotracheal tube can abut against the carina, and that also can increase the peak inspiratory pressure. So we have to keep a close watch on the respiratory compliance also. Surgery related complications, challenges are there. There may be port site complications or gas embolism, which is rare, or visceral injury, which the surgeon will take care of. But you have to tell the surgeon early that there is some hemodynamic instability, so that he takes a quicker action. Then traditionally preferred anesthesia is general anesthesia, because you have got a good ventilation control, and there are various options in general anesthesia like balanced anesthesia, inhaled anesthesia, and TIVA, that is total intravenous anesthesia. Regionals are emerging as safe alternatives, but I have put a red question mark with that. It includes spinal epidural and combined spinal epidural. Monitoring of the patient is very, very important, because you have changed the physiology so much. So you have to, basic monitoring is an ECG, a pulse oximeter, a capnograph, a multi-monitor which has got NIBP, and a temperature. So, and apart from that, you look at the pressure points, which is the anesthesiologist's responsibility. Maintain a neutral neck position, secure the arm below 90 degrees. So usually what happens, if you don't fix the hand rest, it gets hyperabducted and patient can have nerve injuries. And you keep on checking the position regularly. And induction drugs, there are many, and as I said, you can use inhalational or TIVA. So what are the benefits of total intravenous anesthesia is the recovery time is reduced, and post-operative nausea is also less. Similarly, it gives precise control over the anesthetic depth. And if you are using a BIS monitor, that is bispectral index monitor, then it is still better. The advantages of inhalational is it offers a straightforward administration. You can even monitor end-tidal inhalational concentrations with some monitors, and it is cost effective, allowing quick adjustment for different patient needs. And when you are using a muscle relaxant, it is better you do it under a neuromuscular block and monitoring. The airway. So we go by ABC, airway, breathing and circulation. Always safest patient under for laparoscopy is a patient who is intubated, because his airway is secure. It prevents aspiration, it enables precise ventilation, it facilitates good muscle relaxation, and it creates an ideal surgical condition. There are supraglottic airways like LMA, there are 2-3 generations of that, but they have got risks of gastric insufflation, possible ventilation challenges, not ideal if the case goes for a longer time, and its use is very selective. Okay, these are the different types of supraglottic devices which I will not go into. Next is breathing. So the ventilator parameters, we have to use something called as a lung protective ventilation, which is a low tidal volume and high peak. Okay, so the tidal volume we use about 6 to 8 ml per kg per ideal body weight. It is not about the total body weight, it is the ideal body weight. We use a peak of 5 to 10 to keep the distal areas open, and we monitor gases and ETCO2, especially during pneumoperitoneum. Okay, and circulation has to be taken care of with good hemodynamic monitors. If the patient is of high risk, then invasive blood pressure monitoring is very, very important, so that it is a continuous monitoring. And a good analgesia. The analgesia is approached by a multimodal approach. So it should be opioids, NSAIDs, and regional techniques. And you can incorporate preemptive strategies like including acetaminophen or gabapentin, or even steroids are used. Tap blocks and epidural catheters also can decrease the use of opioids and give better analgesia. So post-operative nausea and vomiting prophylaxis is there, and the primary drugs used are ondansetron, dexamethasone, and scopolamine. And this is the enhanced recovery after surgery protocols, okay, which optimizes care through pre-operative carbohydrate loading, minimal fasting, and targeted fluid management, emphasizing on multimodal analgesia and early mobilization. This is the ARAS protocol, which is come for the last 1 decade. Okay, so somebody who prefers spinal, the puncture site is at L2, L3. The advantages they say is avoids airway manipulation and there is risk of hypotension and bradycardia. And if somebody chooses epidural, placement of a catheter at a thoracic level depends on the surgery which you are doing, and maintains respiratory control and stable end-tidal carbon dioxide, but you need to monitor the hypotension. Another thing what I forgot in spinal is you can use segmental spinals. So they use isobaric bupivacaine, so that only the segment which is of interest can be used, but I don't know how much. I have seen lot of articles, but I don't know how much comfortable the patient is. So spinal anesthesia monitoring is very, very important. I always felt that if your patient is under general anesthesia, the monitoring will always be better than when you do a case under regional techniques. Okay. So basically, what people who promote spinal anesthesia say is your use of muscle relaxant is reduced, there is decreased blood loss, post-operative pain control is better, the patient is awake or early awakened, and there is a risk, reduced aspiration risk. And what are the limitations? As I said, hypotension, bradycardia, respiratory compromise, okay, risk of respiratory compromise, especially in patients with pre-existing respiratory conditions. This I can't understand. When they say indications for spinal is cardiac or respiratory problems, so they are telling that they will use spinal anesthesia. But again, the limitation is pre-existing respiratory compromise. So this is one thing which I am unable to understand. So technical challenges are there, and a surgeon who is not familiar to that, try to use the anesthetic technique which the surgeon is familiar. Okay, because ultimately he is going to pay you, he or she. Okay. So I got few articles on it on spinal anesthesia and laparoscopic surgery. So they say that if the patient's BMI is more than 30 or intra-abdominal adhesions are there, increased duration of operation, if there is bleeding or increased intraperitoneal pressure, then these patients have pain during surgery. Okay, but at the same time they say that it did the patient having pain, and definitely if a patient gets pain, he will breathe forcefully, and the surgeon always struggles to do that. But on the contrary, they said they did not affect the surgeon's work on the course of operation, because I work with the surgeons, even a little movement of the toe also they say that the patient is moving. So that is one thing. But their conclusion was, in light of these observations, we are proposing spinal anesthesia for laparoscopic surgery. Okay. So this is another article which I found. They say that under spinal laparoscopic cholecystectomy was done, but I was surprised to see that their mean operating time was only 16 to 47 minutes. Anyhow, I have not met a surgeon who does so fast, and I don't usually ask how speed are you doing. I'll always ask how safe are you doing. Okay, speed, we should not race against time. We should go with the safety of the patient. And they say under spinal anesthesia you should use low pressure pneumoperitoneum, but I think for a straightforward case it should be okay, but for a complicated case it may be difficult. So different intraoperative complications in anesthesia under anesthesia is hypotension, arrhythmia, maybe because of hypercarbia, then hypoxemia, subcutaneous emphysema, shoulder and neck pain is quite common. Okay, so routine monitoring, a stethoscope. Usually when we did our anesthesia PGs, we were made to put one stethoscope on the chest and listen to the cardiac. Okay, then ECG and pulse oximeter is must. Pressure control, you should have a very microprocessor controlled insufflator which keeps the intra-abdominal pressure properly. A neurovascular block monitor, temperature has to be maintained, which in adults usually we tend to forget. But a cold gas can cause hypothermia and delayed recovery. Okay, and in fact the triad of trauma, surgery is nothing but a planned trauma. So acidosis and coagulopathy, they are very and that is a triad which is very dangerous, and hypothermia. Okay, and for a high risk patient, always better to go for advanced monitoring using a Swan gas or a central monitor. And capnography is a must pass. You don't say don't do any laparoscopic surgery without a capnograph, because complications can arise just like that. Coming to hysteroscopy, okay, so it is The choice of anesthesia again depends whether it is a histolaparoscopy or hysteroscopy. I can watch on that if it is only hysteroscopy, it can be safely done under spinal anesthesia. So, what are the complications seen in hysteroscopy are arrhythmias, uterine perforation, the distension media related issues. It can be either fluid overload or a venous gas embolism. Okay, and these are late complications which are more of a surgeon related. So, how do you manage bleeding or perforation? You have to recognize very early, tell the surgeon that it is better to stop the procedure and stabilize the hemodynamics and handle the surgical complication. So, this is another distension media when you use either a glycine or a normal saline. So, you should always monitor how much has gone in and how much has come out. Okay, so your deficit, that is fluid deficit, should never exceed 2500 ml in a healthy individual, and in a high risk patient not more than 1000 ml. So you look for a TURP-like syndrome where the irrigating fluid gets into the vessel and causes hyponatremia. There definitely a regional will definitely help. Because the patient is awake and any change in conscious levels, you may anticipate hyponatremia. Then glycine toxicity. So how to prevent the fluid complications is use sodium chloride 0.9%, monitor the fluid balance, set fluid limits, maintain normal MAP. So that higher the blood pressure, lesser the chances of the fluid getting into the vessel. Okay. Next is venous gas embolism. The gas, where does the gas enter? It enters through the exposed vessels, cervical vacillation or the uterine sinuses. So always the pressure gradient, when you put the patient in Trendelenburg or if the high infusion pressures are used, the driving gas can get into the vessel. The gas sources can be just your coagulation, fumes which may come, they itself can enter the circulation, or the room air because of repeated instrumentation, and multiple reinsertions and prolonged exposure to lacerated cervix are chances of venous gas embolism. So how to prevent it? Patient positioning, avoid exaggerated Trendelenburg. Then your uterine distension should be less than 100 millimeters of mercury. Hemodynamics has to be maintain a normal or a little above MAP, and patient has to be monitored. So early detection of venous embolism is by when there is a sudden decrease in N-type carbon dioxide. You can I got time or it's done?
2 more minutes.
2 more minutes. Okay. And hypotension, hypoxia, and bronchospasm is there. You get a Millville murmur. So what is the immediate response? Stop surgery. Position patient supine. Disconnect the distension medium. Deflate to the uterus and increase the FiO2. Okay. Call for help for resuscitation. This is what you should know. If at all you suspect gas embolism, put the patient in the Durant position, that is left lateral, so that the air comes on the higher side and it doesn't go from the right ventricle to the pulmonary vessel. Okay. So post-operative management, good analgesia, nausea, vomiting, and good monitoring is there. Good analgesia, special consideration is to be careful in obese patients or somebody who's got a cardiorespiratory disease or elderly patient. Okay. Okay, GA means a trained anesthesiologist, properly overlooked patient, ideal operation theatre, proper monitoring intraoperatively and postoperatively. Okay. So stress levels of anesthetics. If at all I was supposed to give an anesthesia spinal for an laparoscopy, I'll definitely be more stressed. Okay. Everybody knows that speed is dangerous. Everybody knows that speed is dangerous. But even a world champion can die prematurely because speed is never safe. So you should always be in your safety limits, whether you are a world champion or a normal person. Thank you.
Thank you, sir. It was a wonderful talk, and we always appreciate sir's talk because he always talks practically, not only just theoretical aspects, because he's very cases of laparoscopically what we have pioneered here, the laparoscopy, advanced laparoscopy. For that, sir.
Thank you, Guru sir, for the excellent presentation.
Sir, you mentioned that anesthesia lab surgeries can be done under spinal anesthesia. The surgery went on well, and the patient asked next day, "Doctor, why did you tie me to the table?" Literally it is like tying the patient and doing the surgery. the respiration is not under control and the aspiration, and we come across a lot of complications who undergo laparoscopic surgery under spinal. So of course minor diagnostic and quick procedures you can do, but major procedures, this is our experience.
Sir, actually I also promote only general anesthesia, but because I found few publications, I had to mention in this talk, sir, just to complete the talk. Thank you, sir.
You have to hide it.
Yeah.
For me, true privilege to welcome Dr. Shailesh Puntambekar, sir, a legendary oncosurgeon and a shining star of the Indian medical community. As the medical director of Galaxy Care Hospital, Pune, Dr. Puntambekar is trailblazer of India's first robotic surgeon and first to achieve a successful uterine transplant in the country. Thank you, sir. His pioneering Pune technique of laparoscopic radical hysterectomy for cervical cancer has revolutionized the field of gynecological oncology, because till then he proved that radical can be done laparoscopy, nobody has dared to do it, and till today also most of the gynecologists don't go for open radical, but you have proved that that has been done and can be replicated if you take a proper training of that. A global icon and mentor par excellence, Dr. Puntambekar has served as an international secretary-treasurer for AAGL and has been honored with the prestigious Golden Laparoscope Award 5 times, a testament to his unparalleled contributions. In November 2024, he has bestowed the esteemed John F. Stew MD Mentorship Award by AAGL, recognizing his exceptional leadership and dedication to nurturing future talent. Let's extend a warm and respectful welcome to Visionary Dr. Shailesh Puntambekar.
Dr. Prabha Desai and of course Dr. Dhanesh Desai, the man behind the woman, not the other way around, because of whom the entire workshop is taken. And thank you, Guru Prasad Rao, that since you have given safe anesthesia, now my job is to start with giving safe surgery. So an excellent talk on anesthesia which always precedes. And ladies and gentlemen, it's a pleasure to come to Gadag. This is my first time. I had an excellent lunch and I'm sure that I will get you out of your slumber in the next 25 minutes when we teach anatomy, because when we learned anatomy in the medical school, we always went back to sleep because that was the most boring subject of our life. And let's see what happens. So hello everybody. This is the Jain Mandir which is near Gadag, and it has a very beautiful Saraswati and Brahma Murti inside. That is what I was told. And this is the knowledge center. So I've come to the place where there is knowledge and everything. So knowledge of anatomy is not a dead weight, but to apply the anatomy in such a successful way that it is the applied anatomy. So as a surgeon, you should be knowing applied surgical anatomy and not anatomy as an anatomist. Knowledge of anatomy is to use how to apply. So we all learn this anatomy in this way. This is where we try to try over the shoulders to see what is happening, and we didn't realize anything because every time the dissection was done, we could never see anything. In 21st century, we are teaching the anatomy with laparoscope, and therefore we can teach more and more people. So laparoscopic pelvic anatomy, this is a book that I have written now, translated into 7 languages. Anatomy this is my term. Anatomy is nothing but the network of fascias, and finding these planes is a mortal duty of us. I always believe that God, in whatever form, his profession was, he was a surgeon. He may be Hindu, he may be Muslim, but he was a surgeon. He created the planes. It is for us as mortals to find these planes so that we can do the surgery very well. It's all about anatomy and nothing else but anatomy. With the advancements of technology, a lot of people come and ask me, has anatomy changed? The answer is no. Our perception of anatomy has changed. Our understanding of anatomy has changed. And these are the 4 things which are very, very important. That's what we are going to discuss. Sacral promontory pelvic anatomy is the most constant anatomy in this world. You may have a gallbladder where there may be 2 cystic arteries, 2 bile ducts. But pelvic anatomy is the most constant. So no excuse, ladies and gentlemen, saying that the anatomy in my patient was distorted. The anatomy is never distorted. It's your mind which is distorted, not understanding the anatomy. So it is the most constant anatomy of the world, and thorough knowledge of anatomy is better. What lies where, when, what comes next, when you do laparoscopy, it is this limited view that prevents you from knowing what it is. And a good laparoscopic surgeon has to know what comes next. Anticipation should be based on anatomical knowledge, and this is the term which is now used worldwide: predictive anatomy. Predict your structures before they come. So as we put in laparoscope, we see these structures which are two obliterated umbilical artery. What is the inference that you draw? The bladder lies between the two umbilical arteries. Now when you want to do birch repair, you will not cross lateral to the median umbilical ligament because the bladder lies between the two umbilical arteries. Simple anatomical concept. And now look at the sacral promontory. Sacral promontory is the beginning of the pelvic area, and there are three things which happen at the sacral promontory. You can see that this is the peak. Whenever in difficulty, this is like an Himalayan peak. You can take any anatomy, any pathology in the entire pelvis. May it be large cervical fibroid, a large fibroid in the uterus, endometriosis, nothing reaches up to the sacral promontory. If that is the thing, why don't you start your dissection at the level of the sacral promontory? And what happens at the level of the sacral promontory? There are three things which happen. The common iliac artery divides into two, internal and external iliac artery. The ureter crosses from the lateral to the medial side and continues to remain as the most medial structure. What is the inference you will draw? If you remain medial to the ureter, you can never damage the vascular structures. That is the most medial thing, and the superior hypogastric plexus lies at this level and it is more towards the left. That is precisely the reason when you do sacrocolpopexy, you fix the mesh on the right side and not on the left side. So this is anatomy. You did it inadvertently, but there is a relation for this. So this is what you can see. This is the bifurcation of the common iliac arteries. The ureter crosses from the left to right, from the lateral to the medial side. Then we come to the fascias of the pelvis. This probably is the most important thing. There are four fascias: the cervicovascical fascia, endopelvic fascia, the Walden's fascia, and of course the Denonvillers fascia. So this is the endopelvic fascia which covers the obturator internus muscle and the levator ani muscle. And if you see this fascia, this is the fascia that you see in birch repair, any kind of prolapse surgery, and this is very, very important. Then what is the relation of the fascias to the vein? Why are we so interested in the fascias? All the veins in the body lie underneath the fascia. So if you lie between the two interfacial plates, you will never have bleeding. That is the most important relationship. So you have the Denonvillers fascia, which is nothing but the rectovaginal space. So when you start this dissection, you can start the dissection from the sacral promontory, go right up to this area. Look at this. We are not using any kind of energy sources, just using the anatomy. Two layers of Denonvillers fascia. One goes with the posterior vaginal wall, one will go with the anterior rectal wall, and you can see how I put my two hands and these two fascias open up. Remember good old days when you put your fingers there, it bled because you went between the fascias and the organ. So this is the Denonvillers fascia. You can see this, and this I will tell you, this is to be dissected with the dictum, which is again a world famous statement: fat belongs to the rectum, remain above the fat. So this is now the cervicovascical fascia. This is the fascia which covers the anterior wall of the vagina, and the bladder lies anterior to the cervicovascical fascia. So you can see fat belongs to the rectum, fat also belongs to the bladder. So you lie underneath the fat, just push, and you will see the cervicovascical fascia. The veins lie below the cervicovascical fascia. In good old days, you used a gauze piece to dissect the bladder. It bled because you went between the fascia and the anterior vaginal wall. This is the most important thing. This is the cervicovascical fascia. The bladder lies always anterior to this. And you can see this. This is the surgery which is with the robotic. You can see the cervicovesical fascia. The bladder lies anterior to the cervicovesical fascia. The vagina lies below, and the veins lie below the cervicovesical fascia. This is the angle where the maximum bleeding takes place. So instead of going after the veins, you just coagulate the fascia. Automatically, like boiling of the egg, the veins will stop bleeding. Simple anatomical knowledge used to do the surgery. Don't go after the veins, just coagulate the fascia and end of the story. How do you dissect this? So this is the sharp dissection that you do tomorrow when we do live surgery. I will show you the same. Fat belongs to the bladder, is the dictum. So you just remain below the fat, just remain below the fat and push. Remain below the fat and push, and you will see that there is no bleeding, no use of energy source, just anatomy, anatomy and nothing else but anatomy. What is the Walden's fascia? This is the Walden's fascia. That is the fascia when Vivek and all the gynecologists do endometriotic surgery. This is the fascia which is behind the rectum, and this is the fascia. Again, this is behind the rectum. This is called as the presacral fascia. When you dissect the rectum, fat belongs to the rectum. When you are going underneath the rectum, go below the fat. Just go below the fat, and you see veins lie below the fascia. That is the dictum that you have to understand every time. This is called as a holy plane of Billiard. This is the way in which the rectum should look at the end of the day. Buttocks of an infant, for the gynecologist, very simple to remember. It should look like buttocks of the infant, and this is the guy. What is the most important thing? All of you wonder when we do laparoscopic surgery, there is no adhesion. The reason is Frank Nater, Gray's Anatomy tells you there are no fibroblasts in the fascia. If there are no fibroblasts in the fascia, there is no fibrosis. Therefore, you do this dissection interfacial. So, significance of the fascias. Fascias cover the anterior wall of the vagina. They cover the posterior wall of the vagina. Only on the lateral side it splits into two. That is called as the cervicovesical ligament, allowing the damn ureter to come there. And that is the weakest space from which the tumor goes away. Therefore, always remain above the fascias. Fascias are the strongest thing to prevent any kind of cancer recurrence. And this is the most important thing. You can go through this publication which got us the second Golden Telescopic Award, Facial Anatomy and its Relevance in Safe Laparoscopic Hysterectomy. This is our publication in the JMIG article. What about the pelvic ligaments? We have all separated the ligaments into three types: the uterosacral, the McEnrods and the anterior thing. It is nothing but a single fan-shaped structure. The uterosacral is nothing but the fibromuscular thing. So what do you understand? If you cut the uterosacral, there is no bleeding. The McEnrods is the most important thing. It carries the arteries and the veins and also carries the lymphatics. So when you do any oncological surgery, it is about the clearance of the McEnrod's ligament and the anterior parametrium, because the rule of the body is lymphatics follow the vein, and therefore you have to take out more and more lymphatics. What about the entire thing? As I said, the cervicovesical fascia splits into two, and that is one of the reasons that you have to understand that you have to prevent any kind of spread from there. What are the deep pelvic spaces? There are four spaces that we are going to understand. These spaces are not spaces, because if you read Gray's Anatomy, space is a space which is lined by the peritoneum. These spaces are called as potential surgical spaces that you have to find out. The first thing is, of course, the pararectal space. Pararectal, parallel to the rectum. And this space is divided by the ureter into the lateral pararectal space called as the Latsko space and the medial pararectal space which is called as the Okabayashi space. So you can open these spaces in two approaches. One is called as a medial approach, where you cut the peritoneum medial to the infundibulopelvic ligament. This is how you can cut the peritoneum medial to the infundibulopelvic ligament. And this is called as the endometriotic approach. We said that way back in 2009, and I will show you that this is the medial approach, that you open the retroperitoneum and on the other side you can see the lateral approach that you open parallel to the infundibulopelvic ligament. The first structure that you see is the ureter. You can see the ureter on either side. Now just remain parallel and lateral to the ureter. You can see parallel and lateral to the ureter, and the only structure that prevents it from going down is nothing but the uterine artery. So uterine artery is the only artery which crosses the lateral pararectal space. The lateral space is called as a Latsko space. The medial space is called as Okabayashi space. The lateral space has the only structures which is of importance is the uterine artery, while the inferior hypogastric nerves lie in the medial space. So you can see how you can dissect the Latsko space. Look at the way in which the Latsko space is dissected. Just open the space laterally. Look at the ureter. Remain. When you are doing even open surgery, try this. Put 2 fingers lateral to the ureter and just take it down parallel and lateral. The only structure that prevents it from going down is the uterine artery. 30 seconds to reach uterine artery. And if you want to dissect the same, the entire thing on the medial side, when you want to dissect the medial, then you just remain parallel and medial to the ureter and you will see the hypogastric nerve. So this is how you do the dissection. Tomorrow you are going to see this entire steps more and more again. Again the pararectal space, you see this is the most important space. Cut the peritoneum medial to the infundibulopelvic ligament, then cut the posterior leaf of the broad ligament. Just cut the posterior leaf of the broad ligament. This is, and then go underneath the infundibulopelvic ligament to see the external iliac artery. Once you have seen this, then you see the ureter remain parallel and lateral. Just remain parallel and lateral, and the only structure that will prevent it from going down, you can see the internal iliac artery. The first structure that will prevent it from going down is nothing but the uterine artery. This is the uterine artery, and then you remain parallel to the uterine artery. This is the ureter parallel to the uterine artery, and that will open up the paravesical space. So this is the paravesical space. You can see on the top the superior vesical artery, and then this is the paravesical space which takes you down. So this is how the spaces have to be opened. And if any one of you ask me which is the most important space that a gynecologist should master, it is this pararectal space, which is very, very important. What about the dissection of the rectovaginal space? This is the way in which it should be dissected. Fat belongs to the rectum, remain above the fat, just remain above the fat, and this is the most important way in which you can dissect this. So fat belongs to the rectum is the dictum. You can see this again, the rectovaginal space being dissected. Look at that, pull the rectum, look at the fat, just go above the fat. Just go above the fat, and this is how you can go above the fat. And then there are 2 layers of Denonvillers fascia. You can see very, very clearly. Again, watch it tomorrow live. This is a very, very important space for people who want to do endometriosis, and this is how it is stuck. You can see the 2 layers of Denonvillers fascia, which is very clearly seen. This is the same way you can dissect. I will not take you this. So this is the pararectal and the paravesical space, the only structure that crosses it. Look at the length of the uterine artery, 6 centimeters. Look at the length of the anterior division of the internal iliac. Long length God has given you for ligation. So don't worry about this. And these are the important things about doing the paravesical and the I've already shown you this. And finally the prevesical space. The prevesical space has to be dissected for birth repair, for any kind of pectopexy. As I said, lie between the median umbilical ligament. Again, fat belongs to the entire bladder. So you remain above the fat. Just remain above the fat, because you have to take the bladder down. Remain above the fat, and look at the way in which you can do this. So visual anatomy, that is the most important thing that you have to understand, and this is the prevesical space which is done. So this is the bladder dissection, which again you can see bladder lies anterior to the uterine artery. Never dissect the bladder going below the uterine artery, and this is very, very important to see. I will not show you all this because this is what we are going to show. And then finally the 4th space of Yabuki. This is the fourth space of Yabuki. This is the space through which the hypogastric nerve will enter into the bladder, and this is the entire area. Again, I will show you this. It is very difficult for you to understand only on this video, but tomorrow I will show you this. So based on this knowledge of anatomy, we also developed what is called as the parametrial revolution, and we first found out that the reason for recurrence in cervical cancer is not clearing the anterior parametrium, also called as infrauretral parametrium, and this is the infrauretral parametrium that you have to dissect and take it out, and this is what we first described way back in 2020. This is the anterior parametrium. When you do open radical hysterectomy, you push the ureter with your thumb, automatically the clamp goes below the thing, but in laparoscopy you have to dissect the infrauretral parametrium, which is called as the anterior parametrium, and this is very important. So you can see this is the tunnel as you take, this is the cervicovesical ligament. When you want to dissect the ureter, this is the tunnel, which is nothing but the cervicovesical fascia, which has cut and split into two. You take two. Now look at this. You apply the two clips. Once you cut that, the ureter will automatically walk away. This is how it is lateralized, and then you open the anterior parametrium, which comes. If you do not do this clearance, 100% likelihood of getting this into the entire area of recurrence in this. So this is how you lateralize the ureter, and this is how you can do this. And this is the anterior parametrium. Again, I will not show you this. The hypogastric nerve which goes through this area into the Yabuki space, and therefore which is important. What are the important things? When I describe this anterior parametrectomy against the LAC trial, which told us to stop doing laparoscopy, we won our 5th Golden Telescopic Award, and this is the entire description of anterior parametrium, a probable answer to pelvic recurrence. Finally, about the vessels, look at the vessels, right from the aorta to IVC, up to the common iliac, to internal iliac, to external iliac. What is common? There is no branch on the anterior surface of the aorta, no branch on the anterior surface of common iliac, no branch on the anterior surface of the external iliac, and that is the most important thing. No tributary on the anterior surface of the external iliac vein. This you can see, and the only thing that you have got, this is the bifurcation. So if this is the anatomy, why is this anatomy? So that you can do pelvic node dissection remaining parallel to the vessels, and because there are no branches. So look at the way in which you can do the dissection. The pelvic node dissection can be done only if, because there are no branches on the anterior, lateral or medial side of the external iliac artery. Did you ever think about this? This is how God has created the anatomy. This is how you use this knowledge of anatomy to do this surgery. Look at that, just remain parallel and push, and that's the obturator vein. So knowledge of anatomy will help you. I will not show you these complications because this is a lecture that I am taking later. What about the internal iliac vessel? There are two divisions of internal iliac. As gynecologists, we are only interested in the anterior division. And there is a long length of internal iliac artery available for ligation. The posterior division immediately dips down to supply the gluteus muscle. So when you want to ligate the internal iliac artery, do not ligate close to the bifurcation. Go a little bit caudally, about 3 centimeters, so that the patient does not get intermittent claudication. So you can see a long length of the internal iliac artery which is available, and therefore in this again I won't show you because this is something which is important. So this is, and of course we also published something which you were not knowing. We were told in Gray's Anatomy that there are only 2 branches or 3 branches of the uterine artery supplying the ureter. When we did the transplant, we realized that there are 9 branches. Again a publication, first time on anatomy. Getting an anatomical publication is very, very difficult. 9 branches of the uterine artery before it goes into the area. So even after clamping the uterine artery, you get sometimes bleeding because there are branches which are there. And this is how the relationship of ureter is. The artery goes above the ureter, the vein goes below the ureter. Again something which is against Gray. They don't go as comparison, and the reason for this, knowing this, is whenever there is a bleeding, you have to understand if it is an arterial bleeding push the ureter down. If it is a venous bleeding, just lift up the ureter because you know that the bleeding is going to come from down. This is the corona mortis. This is where we always fear. It is more for the surgeons, but also for the gynecologists who do pectopexy, because this is a pectineal ligament just above the corona mortis. When you do pectopexy, what is corona mortis? The tributary, the circumflex iliac vein joins the obturator vein, and if there is a bleeding from the internal iliac vein as well as the external iliac vein. This is the entire thing. Now let's talk about what was called, this is the most important thing, that is the ureter. Ureter carries its own mesentery, which I will show you. So you can see the ureter, it carries its own mesentery, and therefore you can take the entire ureter and denude the ureter from top to bottom. This is very, very important for you to understand. So the ureter lies anteriorly is the artery, posteriorly is the vein, and this is the mesentery. It is like the pelvic hot dog. Why is it hot dog? Because this is what we fear, this is what we cause damage if you don't understand the anatomy. And therefore the dissection, again you can see this, the artery goes above, the vein goes below, and the ureter always lies at the base of the uterosacral. So whenever you are in trouble, antivert the uterus and cut at the apex of the uterosacral. Ureter is always at the base of the uterosacral, 2.5 centimeters, just 2 more minutes and I will finish. 2 minutes are there, no?
Yes.
Yeah. So this is, I will not show you the medialized thing. The neural anatomy is very, very important. There are 4 nerves which we are going to see. That is the hypogastric nerve, the obturator nerve. All these nerves I will show you tomorrow. And of course, if there is a time, then I will show you also the sacral nerve and how to dissect these nerves. This is remaining parallel and medial to the ureter, which is very, very important. So this is how you can do dissection parallel to the ureter and just remain, and then you will see the hypogastric nerves which are coming into the picture. These are the hypogastric nerves, and this is very important. Again, I will show you tomorrow. All these nerves we will be seeing tomorrow. So all nerves in one anatomy. Significance is to prevent this, and therefore to prevent any kind of damage to the neural structures. So when we entered the world of anatomy, it was much better. It was not about removal of the organs, but maintaining the functions. The nerves are to be preserved not only for bladder but also for vaginal good thing. I am not going to take you on to all this, and this is our article which says how nerve sparing leads to good sexual activity in fertility preserving surgeries. I will not show you all these surgeries. The only principle to preserve the nerve is to look at the uterine vein, ligate the uterine vein medial to the ureter. Don't try to go for the nerves, because if you are not skilled, don't try to look at the nerves. Just this is one thing that we described way back in anatomy. It is the vein, take the vein medial to the ureter and the nerves will automatically get preserved. So you can see the vein coming from below the ureter, take the vein medial to the ureter, all anatomical concepts which are there. Again, I will not show you all this, all these robotic and everything is not needed, but this is the most important thing. Avascular, this is the latest paper. All of you should read through this paper. This is the 2023 latest paper, where all that we said in 2009, fat belongs to the bladder, fat belongs to the rectum. There are 2 ways of opening the entire pararectal spaces. The medial and the lateral way has been mentioned. So this is the anatomy. This is the roadmap of the pelvis. Ureter is the most tubular structure. Then there is an internal iliac for you, gynecologist. The internal iliac artery which continues as the obturator artery is the Lakshman Resha. Do not go lateral to it and you will prevent damage to this. So you have to spread this knowledge through this entire area, and we have done this. So remaining medial to this hypogastric artery will avoid damage to the obturator artery, and of course the ureter lies in the fourth. Look at the last sentence. There are no variations. After doing 1000 radical hysterectomies, I have yet to find an uterine artery arising from external iliac. If there are no variations in pelvic anatomy, no excuse to say that I will not learn pelvic anatomy. Again, an anatomical publication after the transplant, that not to use the uterine vein, just use the ovarian vein, and this was a publication which was made. We again did history. We did a live uterine transplant. Vivek, Nitin, all have been witness to a live uterine transplant that we did. So in laparoscopic era, what lies, surgeon is always ready with 3D laparoscopy with armamentarium. But finally, it's all about anatomy, and nothing else but anatomy. So this is like McDonald's burger. Why does this anatomical concept survive in the world? You go to any part of the world, McDonald's burger, same size, same taste. This is the intelligence of the Americans. As Indians, we had to create the steps which were duplicable, replicable. Any surgeon living in Nigeria or Brazil can do these steps, and this is what my anatomical concepts have done, and therefore I received this John S. Teague Award for mentoring more than 400 international surgeons right now, and this is our vision. So our vision is anatomy remains constant. What has changed is our perception of understanding the anatomy. Anatomy suddenly becomes easy if you follow these steps, and therefore I always say this, Prabha, this slide is always very famous worldwide. There are 3 C's of success. One is compassionate. As doctors, we are very compassionate. We are always courageous to operate on everyday new patients. But I think if you become successful, the 3rd C is very important, craziness, which my wife will say, I have it in plenty. Thank you very much, ladies and gentlemen.
Well, thank you very much for a wonderful, thoughtful presentation on pelvic anatomy. Now we can have the questions.
I totally agree with the unorthocation of the uterine pelvis.
That is a very good,
so many radical surgery.
that is a very good question.
And what precautions you take and how to identify and how to be safe.
We have encountered double ureters multiple of times. When we have a pelvic kidney, especially in MRKH patients, we have pelvic kidney and we have single kidney. But if you go through double ureters, if you have encountered double ureter, they still follow the rule. The ureter still crosses from the lateral to the medial side, quite common iliac, and continues to remain as the most medial tubular structure. So they still follow the rules. You have a pelvic kidney, you have double ureters, they will always...
To the bladder.
Pardon?
Opening of the ureter, you will double or single?
You double moiety, it is called as moiety in urological language. So double moiety is only till you reach the bladder, then it becomes single one.
Okay.
Then it becomes a single limit. 9 out of 10 times you see the double ureter from the top, but when they enter the bladder, they join as one single unit.
Okay, sir. The second question, sir, just deep uterine vein. We already worried a lot of wounds and bleeding and all. And how is the relation between the superficial uterine vein and deep uterine vein, and how to differentiate it, and what do you do in the radical surgery?
Yeah, so that is another important question, because if you ask any gynecologist why do you get bleeding in hysterectomy, it is always the venous bleeding which is more dangerous than the entire thing. So superficial vein is usually accompanying the uterine artery. If you see, there is a vein which is accompanying the uterine artery, and the deep vein is always below this. That's the number one differentiation. Number 2 thing which is very important for all of us to understand, the deep uterine vein has a diameter of 1 to 1.2 centimeters. The superficial uterine vein has a diameter of less than 6 millimeters. So it is very important. The superficial veins are very, very small in caliber. It is a deep uterine vein. There are 2 deep uterine veins, and then they join as a single uterine vein. Another speciality which, because again of want of time I could not tell you, the difference between the male and the female pelvis lies here. There are no veins, all of you can see when you do open surgery. There are no veins which go from the bladder to the internal iliac vein in a female. In a male, there is a deep inferior vesical vein or a superior vesical vein. The inferior vesical vein in males goes and drains into the internal iliac vein. In females, the inferior vesical vein, tomorrow Prabha remind me to show this live. The inferior vesical vein drains through the deep uterine vein, and the superior vesical vein lies in the cervicovesical fascia, which is called as the uterine tunnel, and they also drain through the deep uterine vein. So this is the biggest difference. So when you do a radical hysterectomy, it is not only of the damage to the nerves, but also severe venous congestion to the bladder. So even after doing a total laparoscopic hysterectomy, not a radical hysterectomy, you might have noticed in 3 out of 4 or 3 out of 10 patients, you will find the bladder dysfunction. It is because of the venous congestion and not because of the damage to the nerves because of this. So it is a most important difference that you have to understand in the anatomy. Again, because of want of time, there are too many things which are there, and 25 minutes is something which we try to cover. But whatever I have told you today, all of you guys remember, and I will show you tomorrow live in the entire surgery what I have said today. Okay?
Thank you, sir.
Thank you.
We are honored to welcome Dr. B. Ramesh sir, Medical Director and Chief Laparoscopic Surgeon, Artis Hospital Private Limited, Bangalore. One of the pioneer laparoscopic surgeon in Karnataka, a highly accomplished surgeon whose clinical and academic contributions have made a significant impact both nationally and internationally. Renowned for his exceptional expertise, Dr. B. Ramesh sir served as a chairman of the Endoscopy Committee of FOXI 2018-21 and has performed over 1 lakh major gynecological laparoscopic surgeries, setting a benchmark in the field. A sought-after speaker, orator, and operative faculty at numerous conferences and workshops. His dedication to advancing gynecological endoscopy and mentoring the next generation of surgeons is truly inspiring. Let's extend a warm and respectful welcome to B. Ramesh. Welcome, sir.
This very good meeting scientifically in such a difficult situation. So I must comment that this should continue in all the areas, not only here. In all the medical colleges and all district places, then only the knowledge will spread. And respected chairpersons, all 3 are my friends, and these are new friends, and all my colleagues and students, everybody. So hysteroscopy, now you heard enough about laparoscopy, anatomy, etc. So the beauty of hysteroscopy is there is no alternative for hysteroscopy. So for laparoscopy, of course, there are a lot of alternatives, like you can do abdominal surgery, etc. Hysteroscopy, there is no alternative for septum or cannulation, etc. And it is considered as the gold standard in the evaluation of the uterine cavity. So that is why it always should be combined hysterolaparoscopy. See, suppose if there is a fundal fibroid, so don't just do myomectomy and come out. There may be some small fibroid which was left out and causing menorrhagia subsequently. So see and treat approach. Here there is no imagination. So you see the polyp, you resect it. You see the fibroid, you resect it. So diagnostic indications, I need not tell you. So the leading indication is infertility, and the second is AUB and recurrent pregnancy losses. Operative hysteroscopy, you all know most of the pathologies in the uterine cavity can be corrected using operative hysteroscopy. So hysteroscopy doesn't mean only diagnostic hysteroscopy, it means operative also. Suppose if you do diagnostic hysteroscopy and see the septum, what will you do? Unless you are prepared for operative also, it becomes an incomplete job. So these are the contraindication, especially you should not do elective procedures when there is bleeding. So ideal time for hysteroscopy immediately after the periods. So please, especially in infertility, don't do before the periods so that the interpretation will be wrong. So whenever there is a thick or the tough cervix which is difficult for dilatation, so you can do the lightening with misoprostol. And the most important part of hysteroscopy is cervical dilatation and negotiation of the scope. So what I have seen people doing, they directly dilate somewhere and just put the hysteroscope blindly wherever they have dilated. So that is very wrong thing. Hysteroscopy is a navigation. So you put your hysteroscope inside the cavity and you navigate wherever it goes. Of course, cervical dilatation, one of the commonest problem is creation of the false passage. So after you create the false passage. So you should realize that you have created the false passage, and probably if you are experienced, you can renegotiate the cavity and complete the hysteroscopy. But if you are not experienced, so please abandon the procedure and plan it after 4 to 6 weeks. So this is the way the hysteroscopy is put in a case of anteverted uterus. So if you go like this, you will be going on to the posterior wall. So first be straight, apply the hydrodistension, the cervical canal and the internal os gets opened up. Then you put your hand down so that the tip of the telescope goes up in the anteverted uterus. So in a case of retroverted uterus, you can see here, suppose if you put in a wrong direction, that is where you will create perforation and false passages. You lift up your hand, and so that the cavity, the slide has to, the tip of the scope has to gently slide the internal os. You should not forcibly, pass the hysteroscope. So this you must remember. If there is some resistance while passing the hysteroscope, that means you are touching some structure and it is not the right direction. So it should easily go under vision. So that is very important. And difficulty in visualizing the cervix. So these are the cases, and you can use vaginoscopic approach without cervical dilatation using smaller diameter hysteroscopes. So out of good vision is the most important thing. So initially when all of us start doing hysteroscopy, so you will see only red on the screen. What is that red? Because the blood is sitting on the tip of the telescope and there is no distension media and there is no pressure, fluid is leaking, and you are shouting at everybody, and you see the red signal there. And please don't throw the hysteroscope instrument if you break. So that is another thing. So all these factors has to be taken into consideration. Proper dilatation, adequate distension, adequate pressure, all this has to be taken into this thing. And one of the commonest is you always over dilate and there is leak from the cervix or patulous cervix already existing, which causes this thing. And impaired vision may be because of the bleeding and subnormal pressure, uterine pressure, and the flow pattern may be wrong, very slow flow and pressure, and there may be tissues inside the uterine cavity blocking. So all these factors should be kept in mind while doing successful hysteroscopy. So in fact, if within first few cases, if you can see the cavity and ostium, you have already done the job. And how to learn the operative hysteroscopy? Go on doing hysteroscopies. Diagnostic hysteroscopy, all DNCs you post for hysteroscopic diagnostic hysteroscopy, do DNC. So if you go on, if you do 50 hysteroscopies, you are ready to do operative simple hysteroscopies like polypectomy, etc. So anesthesia, most of the these hysteroscopies can be done under local, but anesthetist will get angry. We have to please them also. We have to cooperate. Office hysteroscopy, of course, office hysteroscopy is a smaller diameter instruments where you dilate, you distend the vagina and enter the cervix under visualization. So the pressure, the optimal pressure intraoperative, intrauterine should be 80 to 100 beginning. So as if you want to operate, for example, septum, you can go on slowly increasing the pressure. Don't keep the pressure very high, because suppose if it is the endometrial carcinoma and if you are keeping the pressure very high, so it can spill through the tubes into the peritoneal cavity. So gradually increase the pressure so that you will see this. So distension media, all of you know that. So for diagnostic and bipolar receptoscope, you use normal saline. So glycine wherever you are using monopolar and resection, so you use glycine as the distension media. So these are all the various systems of Because of these systems, there were maximum deaths in gynec endoscopy because of improper use of distension media and pumping. So at least this is better. This is giving internal, external compression. Some people put the needle into the bottle and pump the air. The moment the fluid gets over, the air will get embolized. So within minutes you will lose the patient. That you should never do this. So provided somebody monitors this. And of course, if you want to do hysteroscopy, please buy Histromat. So it is not so costly when compared to your diamond necklace and your jewelries. So this is the very good jewelry you can buy. So you must have Histromat so that it makes the procedure very easy. So now many people have Histromat. Earlier, most of the people did not have Histromat. Very frequently, I used to hear that everywhere there are deaths because of during hysteroscopy embolization or air embolism has occurred. That is because of you don't have Histromat. So please have Histromat always. So diagnostic hysteroscopy instruments, these are the, see, every company make one size hysteroscopy. You cannot afford, we are not so affluent to buy all size of hysteroscopes. The standard is 4.5 millimeter telescope and 5 millimeter sheet. So don't listen to that. Next day another person will come, sir, 3 millimeter. Another person will come 2 millimeter, 1.8 millimeter. So don't listen to them. One standard hysteroscope, how many scopes you will buy? It is not possible. And also diagnostic hysteroscopy assembly. So this is the scope and sheet. It should be locked. So the disadvantage of this is that it is a unidirectional flow. The fluid is going inside the cavity, but it is not coming out. So the vision may not be so good with this. So this is another type of scope, hysteroscope, wherein it is called tropeoscope, where it is a very, very useful instrument where the tip is narrow and you use it as a diagnostic scopy, and if you find any cannulation or polypectomy or anything, so you can advance the outer sheath and make it as a operative channel. So this is called tropeoscopy, which is extensively very good use because it is both diagnostic and therapeutic at the same time. So that is the one. And next one, operative hysteroscopy. So whenever you have cannulation or copper T removal or simple polypectomy, so this is the operative sheath outside 22 French, and this is the operative sheath, and this is the obturator with the cannula. So first you dilate the cervix and insert. After that, this goes and the telescope goes, making the operative. So this is how we assemble the operative hysteroscope. Operative means most of the mechanical things are done in this. So the electrosurgical, you need resectoscope. So this is the, you can see this is the sheath with the obturator. So this is the working element, and this is the sheath. Telescope. So it is assembled, everything has got a groove. So you align that groove and lock it so that the fluid will not get lost, and there is adequate distension. And resectoscope, what about resectoscope? Now we hear all types of resectoscope and all sizes of resectoscope. So, but 26 French resectoscope till today is the standard resectoscope, because if you have a big fibroid and a small resectoscope, you will break the resectoscope or take long time for resection. So if you want to buy only one resectoscope, that is 26 French resectoscope. 22 is too small. Fine, septum, polypendol you can do with the 22, whereas 26 you can do all plus even the bigger the fibroids and difficult surgeries can be done. And so these are the difference between 22, though 26 is little difficult for dilatation, but it is a versatile instrument. So except for dilatation, so it is an excellent instrument and most of the urologists use this only because it is a versatile. And I think the friend spoke about electrosurgery, the difference between monopolar and bipolar. So unlike laparoscopy, here if you use bipolar, the biggest advantage is you can use normal saline, wherein the safety margin is higher when compared to glycine. See, the glycine, when you are operating, when more than 1000 ml gets absorbed into the body, you have to slow down or stop the surgery. Whereas saline, you can go up to 2000 ml for operative procedure. Don't think that saline is safe and go on pumping 8 liters, 10 liters and all. The patient will go into pulmonary edema. So how did this happen, sir? My teacher told saline is safe, you can use any amount. That is a very wrong concept, so you should never do that. And these are all the electrodes, the commonly used electrodes. The 3 commonly used electrodes are knife, Pauline's knife for septal resection, loop for resection, and roller ball. And of course drum and so many others are there, but these 3 are the most important thing. So this is the loop electrode, knife, and this is the roller ball. And assembly of the resectoscope, as you know, it is very easy. So this is the outer sheath, dilate the cervix and put with the obturator. So this is the working element, whatever the electrode you want to connect, you connect the electrode and connect the electrical cable there, and inflow, outflow. So these connections are very important. Unless you learn these connections, it is very difficult to do the hysteroscope. Finally, you can see the light cable. There are multiple connections with the resectoscope, so you should know all this practically. And of course, Bertocci scope, all this I mentioned. So why not 22? Why not 21? Why only 22? You make it 22 because they want to say that I have designed this. So you design on 21 or another 20.5. So these are all so don't go for all these type of things. Buy the standard instruments so that you can afford only one set of hysteroscope, not many. So this is the diagnostic hysteroscopy, how it is done. So it is navigation mainly, so put into the cervical canal, negotiate the internal os, and unless you see both the ostium, so never say the cavity is normal. So you can see the panoramic view, and as you withdraw, you take the panoramic view, and so this is the false passage, how the false passage is created. So you can see the surgeon is going into the wall of the uterus, leaving the cavity above. So like what you do is you have to withdraw and go into the cavity or abandon the procedure if you don't see properly. And this is one example of findings in the diagnostic hysteroscopy. So if you see only one ostium and tubular cavity, so that is a unicornate uterus. You can see there is no other ostium on the other side. So it is a unicornate cavity, and always confirm these hysteroscopic findings with laparoscopy. Don't conclude that this is so and so, because if you say it is a bicornate uterus, it may not be. So confirm concurrently with laparoscopy and make the final diagnosis. And hysteroscopic polypectomy is the commonest procedure what we perform. So you can see the polyp sitting there. Smaller polyps you can cut with the scissor or grasper, but such a huge polyp you must put resectoscope and resect from the base. If you partially avulse it, so the recurrence rate will be higher, and to prevent the recurrence rate after polypectomy, so you can give 2 to 3 cycles of progesterone, which reduces the recurrence of the polyp. And so corneal blocks, hysteroscopic cannulation is a very useful procedure. So many IVF people, the moment they see the corneal block, they will push the patient for IVF, which is a very wrong thing. So you must try this, because the pregnancies may be as high as 50 to 60% or even more sometimes. And remember, you have to just cannulate only the interstitial part of the tube. So don't pass the guide wire through and through the tube. So this is it. And so many, especially the IVF specialists, come across difficult embryo transfer because of the stenosed cervix. So this is the most difficult procedure in hysteroscopy, how to overcome this. So you can see this is the totally stenosed cervix. So what you do is you put the operative sheath into the cervical canal and dilate the internal os with the scissor and the grasper. You can use even monopolar needle and make incision. Then see, the dilatation is going on. Otherwise it is impossible to enter into the cavity. So you have to do something to dilate the internal os. So then once you do the internal os and dilate and leave it, so it will recur again. By the time they plan the embryo transfer, again it will get stenosed. What you have to do is, you have to do the resection of the internal os. So you can see now after dilatation we have put the resectoscope and resect, suppose in the case of retroverted uterus, you resect the posterior internal os, wall of the internal os, or in case of anterior, opposite. So you can see this now slowly we are the cutting with the monopolar needle. So once the resectoscope is put, so you can see the resection of the internal os is being done. So this is not so commonly practiced, but I would advise, so all of you, especially those who are practicing IVF and infertility, many times difficulties because of the stenosis of the internal os. So you have to resect the internal os so that the catheter goes very easily at the time of embryo transfer. That is one. And this is the one example of caseous tuberculosis. I think now the tuberculosis incidence is coming down quite good. So you don't see, these are all the old cases. So if you see a case like this with caseation and obliteration of the cavity, it is most likely tuberculosis. And you send for, don't believe PCR, so you do all the tests and do the clinical examination, everything. And this is the retained products or the post-necrotic tissues following adenomyomectomy. So you can see the necrotic tissue. So RPOC looks similar. So never do blind curettage of the retained products of the pregnancy after MTPR termination. You always put hysteroscope under laparoscopic guidance and evacuate smoothly. So that is another biggest use of hysteroscopy. So this is a case of submucous fibroid, and this is a chronic endometritis looks like. These are the reddish areas and deer skin appearance. So these are all chronic endometritis. Of course, fibroid is also there. So chronic endometritis is one condition you must identify, otherwise you will not get the pregnancy if you don't treat this. And myoma resection is one of the difficult surgeries. So beginners, don't jump into myoma resection unless you do the polyps, septum, etc., cannulation. So again, resectoscope is a gold standard method for this. And if you have a bipolar, you can use saline, or if you have you use saline, and if you have monopolar, I don't think it doesn't make much difference. Depends on the speed and the pressure how much you put, because everybody cannot buy bipolar resectoscope and all these gadgets. So, and another dilemma is whenever there is a large submucous fibroid, so there is a confusion. This size of fibroid needs at least 2 to 3 sittings. So instead of doing hysteroscope, and they will develop a lot of complications, pulmonary edema and fluid overload, all these things. So these big fibroids, if it is even type 0 fibroids, they should be done laparoscopically. So immediately you convert it to laparoscopy, cut the fundus, take out the fibroid and suture. So you can see here it is going on. The fibroid is easily approachable and easily comes out. And probably after good suturing and all, maybe after 4 to 8 weeks, you can do recheck hysteroscopy to see if there are any adhesions. So hysteroscopic adhesiolysis, so I think tuberculosis and PI and post-surgery, DNC, MTP, all these are the causes of Asherman. So adhesiolysis is one of the most difficult problems in infertility to deal with. So you can see here, so like slowly, and it is not always tubular cavity or dense adhesions. Many times it is just flimsy adhesions, or where you can just break with the telescope. So here you have to use the scissors or the resectoscope or whatever. So I would prefer scissors because the damage, the endometrial damage will be much lesser. This is septal resection. All of you know how to do this. So this can be done with both scissors as well as Collins knife. I would prefer the scissor for thin septum and Collins knife for thick septum. So suppose if it is a thick septum, it is very difficult to cut with the scissors. So you have to use the resectoscope. And the appearance of the endometrium, you should know how the proliferative endometrium looks. The proliferative endometrium looks very thin. Even if you scratch, you don't get much endometrial tissue. And you can see this, there is a tubal block here. So bubble side, so if the bubbles are going freely into the ostium, so it indicates that the tubes are patent. The next is secretory phase, wherein you can see the thick endometrium here. So you should be able to make out which is proliferative and thick endometrium. Yeah, for another 2 minutes. So this is the perforation and morcellator. Of course, this is not. It is not great to buy this because how many? It is used only for big fibroids. So most of the cases you will be able to handle with the resectoscope. But if you can buy 5, so it will increase the speed and this thing. So another biggest advantage of hysteroscopy is stem cell injection. Now in infertility, stem cell treatment is a big role in the same. So both for thin endometrium and recurrent implantation failure. So we we take the bone marrow, stem cells from the bone marrow and inject subendometrially into all the 4 layers. So they give stem cells plus growth factors plus plasma. So that is to be injected in this. And so with this we have so many cases for last almost 6 years. So bone marrow stem cells we have done 13, for implantation failure 10, for thin endometrium 3, and out of 13 we got 9 pregnancies and 3 aborted, and we got 6 births, live births, peripheral subendometrial. So this is the comparison between the bone marrow to prove that bone marrow endometrial cells or stem cells are better. So here we had selected 20 cases, for implantation failure 13 and thin endometrium 7. So we got only 9 pregnancies out of 10 and 2 abortions, so 7 live births. So that means, like if the patient cannot afford this bone marrow stem cells because the cost is more, they can go for peripheral stem cells after trying the PRP or whatever, BAPC intrauterine. So hysteroscopic Marina fixation, Marina is widely used. Same time the expulsion rate is also very high. So all of you have seen in the journals that how to fix the Marina hysteroscopically. So what we do is we pass 5 mm scope. Under vision you put 3 mm or 5 mm laparoscopic needle holder, put the thread. This is our modification and this is to be shortly published. So this you take a non-absorbable suture, take a bite through the posterior wall and so tie it to the, so earlier it was tied, not tied to this thread. So now it is, see it is pulled, the non-absorbable and the needle is pulled, and now you thread and tie this Marina here and pull this thread, it will go into the cavity. So now you cut off this and tie the thread, non-absorbable thread to the Marina thread. so that you don't have to make inside, not inside the cavity. The biggest problem was to make the knot inside the cavity. Now we have overcome making the knot inside the cavity by tying the thread to the Merina thread so that it will not come out. So this is a very successful way of, otherwise patient will keep on coming because they will have adenomyosis, we will keep on putting Merina and they will keep on coming. So you can fix it like this whenever there is a expulsion of this thing. So once again I invite all of you for our recent advances called RAGE. For last 25 years we have been conducting, for last few years we were after Corona we couldn't conduct for various reasons. So this 6th and 7th September at Bangalore, so you will be getting the details and the information shortly, all of you, and whoever is interested to present research papers, that will be given top priority for to present in the conference. So thank you very much.
Thank you, sir, for the enlightening talk. Any questions from the audience?
Sir, I tried your technique of fixing the means how you insert under vision that 3 mm needle holder, and then what size of needle?
Yeah. See, this is you have to take a non-absorbable size number 2 because the needle is thick and it is easy to take the bite. If you take small the thread and needle, it is not possible to suture it.
Okay. No, and how much diameter office cystoscope only?
A small telescope, say 2.8 or 2 whatever, smallest
diagnostic scope.
And by the side of that needle holder goes. And keep your scope just above the internal thread and the needle. Catch the thread. How we do laparoscopic suturing? So catch the thread and take a thick bite through the posterior myometrium. It should not be superficial. Then pull it. Then to the other end the Merina is tied. Once you pull this, the Merina will go inside. Then you tie both the threads, non-absorbable. So, but the problem is making the knot inside the cavity. It is little difficult. So that is why what I showed was, so you take the bite, pull it, and tie the ethibond suture to the Merina thread, so that you don't have to make the intercavitary knot. The knot can be done outside and pushed in.
Like example.
Not pusher, or even with a grasper you can push it.
Yes, sir. Thank you, sir.
And sir, even we
I welcome today's speaker, Dr. Shah, a young and dynamic endoscopic surgeon known for his exceptional expertise and energy. A recipient of numerous awards, Dr. Shah holds records for removing the heaviest PR fibroid, the largest para-ovarian cyst, and performing hysterectomy in male. With an impressive tally of 65,000 laparoscopic surgeries, he has also established multiple articles in national and international journals and trained countless gynecologists. Let's welcome him with great enthusiasm. Welcome, sir.
Thank you for your warm welcome. I congratulate Prabha for inviting me and the Gadag Society and for this wonderful workshop, and I can see the hall is full, and tomorrow I am sure we will have an extravaganza of surgical feast by all the stalwarts here. So definitely a lot of learning is coming in these 2 days, and I'll do little bit of my part. This topic is given to me, electrosurgery, which is very well neglected by all juniors, seniors, everyone in the OT, because we don't understand what is electrosurgery. The scope and scalpel are the best friend of the surgeon, and we forget about the electrosurgery unit. हम हमेशा बोलते हैं cautery machine दो, give me the cautery machine. What is cautery? If you hit a rod and put a like something and it will burn, that is cautery. So are we using cautery? No, we are not using cautery. What we are using is electrosurgical unit. So we have to change the nomenclature from the cautery to electrosurgical unit. So man behind the machine, we always listen that man behind the machine and the machine behind the man works. And that's what is called as a technology. What if the technology beds? The outcome definitely will reduce. your quality will reduce, your safety margin will reduce, but if you have a good quality instruments or electrosurgical unit, your outcome will be definitely a good. And so here, if you have a good equipment, but if you don't have a good surgeon who understands the machine, the outcome is still going to be bad. Okay, because if you don't understand how to use the machine, it's going to be very, very poor. I get a lot of calls. I have an underwater cautery. Can I use bipolar saline resectoscope? I say no. You should have bi-TUR component in your cautery. You have to look for bi-TUR component. Only then you can use bipolar saline resectoscope. So this small thing is very, very important. This is what we have in our armamentarium. This all are the gadgets, and we use this in and out in our OT for the better outcome. So let's make through the principle of electrosurgery, and these are the various energy sources what we use, like unipolar. Gynecologists are very much feared of monopolar current. Monopolar nahi, once hota hai, we will not use it. But surgeons uses right, left, center. Even if you see international videos on pelvic lymphadenectomy, they use Caesar with monopolar cautery or electrosurgical unit. So that is what the difference is. So why will come to you. Have you ever noticed why our patient will not get electrocuted while we are using the electric pencil for the, okay, now he is using that pencil with the naked hand. We use gloves sometimes, and then also we get spark and burns in our hand. Have you noticed why? And then we say that gloves, there may be hole in the glove, that's why we got the current. No, that is not the case. Okay? This is the way. Why we don't get electrocuted, even if you use the pencil and directly apply to your finger, you will not get current, because what we use in electrosurgery is more than 200 kilohertz electricity, and our household appliances are at 60 hertz. That's why we get that current switch, electric current laga. But in this case, above 100 kilohertz, there is no neuromuscular stimulation. Okay, so no neuromuscular stimulation above 100 hertz. So what we use is 200 kilohertz for electrosurgery. That's why we do not get any, if patient is not getting electrocuted or will not get electric current. So why the training is important in this subject? Because if you are not trained, there will be a poor outcome, there will be patient injury, and there will be a litigation. We are now more worried about litigation rather than anything else. Patient अच्छा हुआ नहीं हुआ चलेगा, litigation नहीं होना चाहिए. That is what the fear is. We have gone to the defensive medical system nowadays. We defend ourselves. Before doing any procedure, we think twice. What will be the complication? What will be the outcome? Whether I'll get sued in the court of law? That is more important. So what are the bases of surgery? Either we remove pathology, replace, repair, and reorganize. So there is a sharp balance between the cutting and hemostasis, and that's where the efficiency of the machine and the time is important. That will come to this. So how we augment hemostasis? In surgery, what we do? We ligate, cut, and you want to achieve a hemostasis so that patient goes home safely. So there are various components. What you can do, either tissue compression using a stapler, tamponade, or you can use a topical agent like cellulose, collagen, Surgicel, or energy modality, which is monopolar, bipolar, ultrasonic, and advanced bipolar. So these are the various instruments which are available. What are the principles of sealing? The tissue damage and clinical outcome. Why the lateral tissue damage is important? We are more worried about the lateral tissue damage. But a thermal spread hoga, and there will be a lateral thermal spread injury to the ureter, which is very close to the uterine artery. So we are more important about knowing the lateral tissue damage also in these cases. So lateral thermal spread depends on all this condition, energy source, what we use, tissue type, water content, time taken, and peak temperature which develop at the tip of the instrument. These all are very, very important things. So final outcome is these two aspects. One is uncontrollable factor, which is biological factor, collagen, elastin, and water factor of the patient. And other side, it's a controllable factor, which is a physical factor, which depends on your instrument, what you are using, the compression you are using, the heat which is generated, and the time taken to coagulate the tissue. This causes the better outcome. Either it can lead to healing and repair, or thermal damage and inflammation and complication. So these three things, combination of this compression, heat, and time is very, very important in the better outcome. So here is the comparison chart between monopolar. You can see monopolar, the compression effect is nothing. How many of you are using monopolar hook to open the vault? There is no compression. There is a single blade, and you just apply on the tissue and it cuts. Okay, so you don't apply any compression. So there is compression factor is very, very less. As you can see the bar. Second, heat generated is very, very high in monopolar, whereas the time taken is very less. As compared to traditional bipolar and advanced bipolar, you use more of compression, heat is generated and time taken is little more, whereas you use ultrasound, everything is less, compression is less, time taken is less, heat generated is less. So this is how you can, just a pictorial essay, how you can efficiently use your energy sources. So monopolar and bipolar are low cost instrument, they are reusable and everybody uses in their OT. Advanced bipolar, yes, costly because the probes are disposable. An ultrasonic device, definitely it's again a disposable, adding to the cost of the surgery. So basic principle of electric surgery is, we will not go into the physics of current, voltage and resistance and all, but definitely this is the chart for the monopolar. Those who are using monopolar in and out should understand this chart. That left side is a pure cut current. It's a very, very low voltage current, you can see. On the other side, coax current is a very high voltage current. Okay, so there is a temperature which developed here is very high. It may go up to 500, 600 degree if you keep on pressing your pedal. Whereas if you use a low voltage current, the temperature at the tip of the instrument is very, very less. So there is no lateral thermal spread. Okay, we are worried about lateral thermal spread and lateral current spread. Okay, here we are talking about the thermal spread because of the heat which is generated at the tip of the instrument. So whenever you want to use monopolar, especially when we are opening the vault, we always use pure cut current. How many of the surgeons you see, they take incision and then entire surgery they finish it with the electric pencil only, with the help of the pure cut current. We never see the generator, we always see the effect, wow, wow and wow. बहुत अच्छा surgery हो रहा है, it's going very nicely. But we never bother to check what are the settings on the electrosurgery unit, what type of current he is using, what type of pedal he is using, whether he is using yellow pedal or a blue pedal. Most of the oncosurgeon will use yellow pedal. Whenever there is a bleeding, they will switch to blue pedal. Blue pedal means extreme, where the temperature is very high, voltage is high. Now, what in monopolar, the application of this plate is very, very important. Okay, if the plate is incorrectly placed, definitely you will have an exit burns. Okay, like this is the monopolar. The current is coming from the generator through the pencil, goes to the tissue, and then with a dispersive plate or a patient plate, the current will come out. Okay, so this is very, very important. Now, this is how we use black plate. How many of you use this rubber plate? How many of you use steel plate wrapped with a wet cloth? Nobody? It's cheapest. Why? Okay. So this plate is not good. Even metal plate with a cloth, wet cloth around is not good because your surgery lasts for 1 hour and that wetness will evaporate within 15 minutes. And then that cloth is dry and there is no conduction, which is, the spread of the current will not there, and there will be concentration where you may have an exit burn. So this is not to be used anymore, this plate. What you have to use is something called as whenever you buy the generator, you ask your vendor whether it has an REM, Return Electrode Monitoring System. Okay, so which is called as a split plate. You have a 2-part in the plate. If you have seen that silver disposable plate, there will be 2 silver part in that. Okay, if you see single silver big plate, then that is not an REM plate. Okay, so what happens? These are the exit burns. Okay, sometimes you get burns like this if your plate is not in contact. This is REM system. Now you can see that plate. Okay, so you can see now the current is activated and one person will remove that patient plate from the hand. See what has happened? Current has stopped flowing. This is REM system. So when your patient plate is not in contact more than 50%, current is not going to flow. Okay, so this is safety. So you should understand what generator you are buying. Okay, older generator will not have this REM system and they are not compatible with this plate also. Okay, so you should need to know what to buy. So monopolar current is very, very safe if you take care of all these things. Coming to bipolar, now very less people are using monopolar, but still with the comeback of robotic surgery, suddenly monopolar has gained popularity. Okay, So we are reducing our energy sources nowadays. For last 10 years we tell monopolar is bad, we have to use harmonic, advanced bipolar, and suddenly with the coming back of the robot, people have shifted back to bipolar and monopolar. So now the current is same, but this safety has to be incorporated. Now coming to bipolar generator, everybody knows that the current is between the two plate of the instrument. Okay, so there is no return plate monitoring, only one active blade, one is passive blade. Current is flowing in between two blades, and whatever tissues are in between, it will either coagulate or cut depending on their compression and what kind of current you are using. Nowadays we have a bi-cut current, which is another type of current which we are using it regularly. With the ligate you coagulate, and with the bi-cut current you cut, which is a high amplitude current. This is a typical bipolar plate. You can see the current is flowing between the two plates. Okay, many times it sticks, you know. So what is the trick is you lift up, you open the jaw before lifting up the pedal. Before stopping the current, you are supposed to open it. Okay, and whenever there is a blood, try to clean the tip of the instrument with the hydrogen or a saline and keep it dry. Otherwise, it will get sticky and you will have more damage to the veins. So these are the typical tissue effects with bipolar, you know. First there is an edema, then duration, when the temperature rises, the desaturation starts, then coagulation, and above 100 degrees, it's a desiccation and evaporation. What is advanced bipolar? This was the normal bipolar, but advanced bipolar, everybody has got ligation and seal. Okay? So what is this? The normal bipolar, the current will go by the side of the tissue from one prong to the another. Okay, this is how the circle arcing, and you can see the bubbling and vaporization by the side of the bipolar forces. But what happens in advanced bipolar, there is something called as a PTC technology. The current is flowing within the arm of the blade, and it will not pass through the lateral side. So lateral thermal spread of the advanced bipolar is practically nil. What is the temperature at the tip of the monopolar? Anybody? How high it can reach? It can go up to 200 to 800 degrees Celsius. If you keep pressing your pedal, it may go up to 1000 also. Bipolar, it can go up to 200 to 400. But with this PTC technology, it will never cross 100. Okay? Why? Because this is the NCL, you can see the blade is activated, and you can see there is no lateral charring or anything. Why? Because the current is flowing inside the two blades. And this is something called as the PTC technology, because these are the molecules inside the tip of the grasper, and when the temperature crosses 100 degrees, the molecule disintegrates and no more current spreads. So at any given time, the temperature of the tip is not beyond 100 degrees. So that's the safety in this, but definitely this will come with a cost because the probes are disposable. So once you can see the temperature is now more than 100, the molecule disintegrates, there is no flow of the current. So at any given time, the tip temperature is not beyond 100. So this is the same NCL, you can see there is no spread of the thermal damage, and there is a blade inside which helps in cutting the tissue. Now this is very important approach. So whenever you cut the uterine or any major vessel, you are supposed to cut in the perpendicular nature, because the diameter what opens is 5 mm. If you do oblique, suppose if I am operating from the left side of the patient, if I am doing the left side uterine artery, my grasper will be perpendicular. But suppose if I am taking opposite uterine from the opposite side, what will happen? My grasper will cut like this. So the vessels open in oblique diameter, which is more, and that's the reason why there is a bleeding more on the opposite side. So always remove your grasper, come from the opposite side, and try to coagulate and cut at the perpendicular to the vessel. This is the ultrasonic scalpel. Everybody knows what is the mechanism of working pattern. It's an electric. The generator has an electricity, and via this electricity, this is a piezoelectric crystal which converts the electrical energy into mechanical energy. And from here, the vibration goes to the tip of the instrument. Okay, so there is no current at the tip of the instrument. It's only vibration which is giving the thermal effect, and this helps in the cutting and coagulation. So this is how it works. When there are two foot switch has a two part, minimum and maximum. When you use minimum, the displacement is minimum, and when you use maximum, the displacement is fast. So whenever the displacement is fast, it will cut faster than coagulation. And when you use minimum, the displacement is low, it will give more time for coagulation and then it will cut. So just to demonstrate how the harmonic works, it has one passive blade and one active blade. Active blade is non-mobile, passive blade is movable. Okay, and the active blade vibrates and creates a gravitational effect. That is another advantage of harmonic, that it creates a gravitational effect, and with the help of CO2 you get a good plane of dissection. And the another plate has a pad in it which gives the compression effect. This is a cordless covidal harmonic where the generator is behind only and the handle has a battery. So you don't have another generator machine in your OT. There is a thunder bit which is a combination of bipolar and harmonic in the same instrument. So there is no change of instrument. You can perform better. You have a 2 different paddle and a 2 generator, and with a common cable it goes to this. So there is a bipolar effect. You can use as a bipolar, and when you want to use as a harmonic, change the paddle and you can use as a harmonic. Coming to few lasers, there's a laser nowadays. People use more of laser in cauterizing the superficial endometriosis, and definitely some plasma is also there nowadays to help you in the cauterization and cutting. This is just to complete the list in the energy sources. And after that, you just calculate with the laser. The depth of penetration is hardly few millimeters, so there is no more tissue damage. Only first layer of the cyst wall is getting damaged. So electrosurgery is a confluent of knowledge, precision and modern technology, making surgical procedures safer and efficient. Thank you.
Well, we are open to the question and answer session. Can we take questions later, sir? No?
Yeah. What is tripolar something? I also never use, but recently somebody was saying we are demonstrating tripolar. Anybody is using?
Anybody has used and can comment on that?
Yeah, really.
Some of the ligation probes,
Okay, sir.
some of the advanced bipolar probes, they have incorporated monopolar hook.
Okay.
It adds change. If you require use of it, you don't have to change the probe.
Okay, okay.
So basically all energy sources are an harmonic one instrument. So
training in endoscopy yesterday, today and tomorrow. We are on, sir. Dr. Desai sir has held prestigious roles such as ex-president of ASI Gadag branch and ex-secretary of IME Gadag. He is also the founder director of Gadag.CME Center and director of IME Blood Bank Society Gadag. Dr. Desai sir is a pioneer in pediatric laparoscopy, having completed advanced training and conducted workshops at national and international levels, including as an international faculty at the Research International Conference in Nepal. His special interests include laparoscopic surgeries, pediatric surgeries, and urology. He has presented numerous papers, posters at conferences like IAPSCon, MASICon, and Pedicon. Let's extend a warm and respectful welcome to the exceptional Dr. Desai. Thank you, sir.
And all of them have got some training centers. So similar training centers are all over India and abroad. So my intention here is to guide young surgeons and surgeons practicing in smaller places to go for training and which part of India they should go for training and where they should get the training of their own choice. So I will start this quote wherein the legendary surgeon of 19th century, Moynihan, emphasized the fact that the careful tissue handling, delicate tissue handling will give the best outcome and best post-operative results. So coming back to training part, we have to sincerely ask ourselves, these three should have training and where we should have training. Why we should have training? All of us want our patients to be hale and healthy. They should appreciate your skill. They should be without any complication. So we have to give optimum results. For that we should have training. And secondly, to safeguard ourselves from legal litigations and other problems, we have to have good training as well as certification. And with this good training, we will have improved efficacy and we will have better practice in our life. And most important is our self-esteem. And every surgeon here sitting, after doing excellent surgery, they will have very good sleep in their night. So when we should have training? In the beginning of our career, in the middle of our career, or far end of our career. Especially those who want to practice in smaller places, they should have proper training in the beginning of their life. That is because in corporate hospitals, if you start your practice, you will have somebody to help you or some seniors to guide you. But in smaller places, you don't have any one of them and you have to guide yourself. So, in the beginning of your career, before hurrying for practice, you have to go for training and fulfill all your needs and come back and start practice. And after few years, you will be lacking in upgradation, so you have to go for short courses and train yourself to and upgrade your knowledge and come back. And far end of your career, many of the doctors, you saw Dr. Guru Prasad in the morning, at the age of 50, 60 years, he went for training and got his diploma in European diploma in emergency care. So where you should have? It depends on your place of practice, your existing expertise and type of patients you are catering as well as your professional goal. All of us should have our professional goal because by the end of 5 years where I should be, you should be knowing it now only. And coming to type of students, all of us are students once or the other time. So there are students who by only seeing the YouTube videos of legends, they start doing operations. And many of the times they are successful also. That is because the skill is very good and the knowledge is optimum. But that is not correct because you may escape for 100 times and 101 time you may get some problem. So you should have at least some certification and training. Second one is like Arjuna. He has excellent skill, knowledge and ability. At the same time, he has excellent facility of training. So he is the ideal student according to me. Third one is Ashwatthama. He has got excellent facility but no intention to learn. They can become very good managers and they can employ Arjunas to operate for them. Teachers are also like Parashurama. They have very good knowledge, skill, ability and extraordinary teaching ability. But they are very moody. You don't know when you will be fired out. So the other one is like Dronacharya. They are polite and very good teaching ability. At the same time, excellent facility also, and they are ideal teachers. And next is Chanakya. He has very good knowledge, skill, but he makes you to earn your knowledge. So, if you are trained under Chanakya, then you will definitely become an emperor one day. In the previous era, all the teachings were teacher-centric. Some of us are faced like we had to wait for 1 year, 2 years to get a training course admission. At the same time, they were very costly. Many of them are abroad and very few centers were there. And definitely they were expensive. Now there are numerous centers. As I told, all the surgeons sitting here are one or the other training centers. Almost all are protocol based. So you need not worry whether it is good or not. Only thing you have to see is how many patients input is there, how many surgeries are being done and what is the protocol. Then you can definitely go for the training. So now you have a choice to choose your teacher as well as a training center. With this background, we'll brush about the history, because without knowing how much struggle our forefathers have done, we will not be able to understand what is the luxury we are enjoying. So, for example, this is just a beginning of light source. In 1806, Bossini developed Lister, wherein he used lens to direct the light or distally. Same thing is modified by using multiple lens by Demoxus. Niche was the first one to develop cystoscope by using electrically heated platinum wire as the illumination, and later on he used Edison's light bulb to illuminate his scope. So that is what I say, lateral development in other fields will definitely help medical practice. George Telling was the first one to do laparoscopy in dogs in 1901, and he used his niche cystoscope to visualize intraperitoneal structures. It took almost 10 years to go from dog to human. It is the Jacobius who did first laparoscopy in humans as well as first thoracoscopy in humans. So he used the same cystoscope but did laparoscopy in humans. He did it under local anesthesia. See the development. Burnham used proctoscope for laparoscopy. So, coming back, in 1901 was the first laparoscopy done on dogs. Then Culp was considered as the father of laparoscopy because he invented multiple scopes, distal weaving, multiple angled scopes. And for your information, the first appendicectomy was done by Kurt Sem, who was a German gynecologist. Coming back to insufflation, in 2020, Zolkofer was the first to introduce carbon dioxide for insufflation because it easily gets absorbed in the body. Later on, several modifications were done. Stone introduced gasket to prevent leak of the air. Similarly, as I told, Culp was the first one to introduce oblique telescopes with the 135-degree angle. It is a real lens wherein the illumination played very important role in development of laparoscopy. In 1960, code light was introduced by Karl Storz, and 1965, Harold Hopkins and Karl Storz again developed broad lens system. And 1986, computer chip television was introduced, and it is under use. In early 2000s, Da Vinci surgical system was introduced. Today, almost all of us have 2D laparoscopy, high definition 4K output, medical grade monitors, warm carbon dioxide insufflators, LED light source, and some of us have got 3D laparoscopy also. So coming back to learning, all of us have completed 3 years of course in our medical school, and many of us are not very happy with what our laparoscopy skills are. That is because we don't get everything in our 3 years of learning. So we have to go for further learning as per our need is concerned. So there are university recognized courses, there are association recognized courses like IIG, FOXY or ASI, and there are training center recognized courses like CMAS, where they themselves train and give their certification, and national board recognized courses like Diplomat of National Boards, NBE recognized courses. So what are the degrees given? Fellowship in laparoscopy, it is usually 1.5 year course. It is recognized by University of Health University, and it is very good course wherein many centers of excellence are recognized by university itself, and you will get proper degree as well as training. diploma in laparoscopy, you can get it for 2 years. Fellowship and diploma in laparoscopy combined together you can get. And fellowship in robotics. Masters in laparoscopy, it is a 3-year course. PhD in laparoscopy, it is a 3-year course. FNB, Fellowship of National Board, it is a 2-year course. And Diploma of National Board, it is in minimal access surgery as well as Gynae endoscopy. So it is a 3-year course. You can go for training abroad also, USA, Europe or Dubai also you can go. So certain things I want to say, this is started in 2000 but still it is under learning process. Many of us are doing it and some of us have left also doing this because it is still not very sure how much useful it is. SILS is a single incision laparoscopic surgery wherein there is a port wherein 3 instruments can be pushed, 1 telescope and 2 instruments, and majority of times small urologically small nephrectomies, cholecystectomies, appendectomy and gastric band surgery, and gynec surgeries like ovarian cystectomies and salpingectomies. These can be done very easily with single port. The problem is with ergonomics, angle of manipulation and other things are very difficult and it requires little skill and expertise. Only drawback is difficulty in manipulation during surgery, and post-operatively there is very bad incisional hernia most of the time. That is the dreaded complication. Natural orifice transluminal endoscopic surgeries, it is also under progress and it is a very fancy thing. There is no scar and endoscopy is passed either through stomach and stomach wall is opened, enter the peritoneum and do the procedures like ovarian cystectomy, appendicectomy, these things. And you can go from vagina, transvaginal also you can go, it's a natural orifice transluminal. The advantage is there is no scar seen outside. These are the instrument handles wherein they are very delicate and sophisticated but costly also. This is the demonstration of transgastric gastrojejunostomy, wherein the loop of the jejunum is pulled out through the stomach and sutured from inside. Similarly, notes appendicectomy, which is very common. From the stomach wall, they go and do appendicectomy and come out and close the stomach. This is transvaginal procedure. You go through the postiphonics and enter the peritoneal region and do whatever you want. Cholecystectomy, appendicectomy, ovarian cystectomy and others. So we have progressed from a long abdominal scar to multiple port side scars and no scars. These are the alleged benefits: no surface incision, reduced surgical site infection, reduced visible scarring, reduction in pain analgesia. These are all claimed but not very sure, because other day I had a newspaper cutting wherein one notes appendicectomy transgastric was done in JJ hospital and patient stayed in the hospital for 8 days. How many of us keep appendicectomy for 8 days? And finally that patient was operated for 2 cesarean sections. So the scar doesn't matter, the result matters. And the dreaded complication is if there is a leak from the stomach incision, you had it. So what is kept for us in tomorrow? And many of us working in corporate hospitals have seen robots, and it is no more tomorrow, it is today only. But only the moment the cost of the robot comes down, each and every hospital in smaller places will also have a robot. Why robotics? Because you can reach the place where the routine laparoscopic surgery cannot be done, especially in pelvis as well as the hiatus. So it is very good for those cases. So it is studied that conventional laparoscopy and robotics has got a upper hand. Here the surgeon works out in the console and the slave arms will be placed inside the abdomen, and with the help of the robotics they can perform the surgery. The advantage is the mobility is excellent. You can have 360-degree mobility, wrist rotation and other things. See the precision of robotic surgery here. This you cannot replicate in open surgery. You have some motion artifacts, you have some defect. See, the precision with which the robot is operating is wonderful. So it is a great skin peel which is done so efficiently. The same can be done on humans also. This type of precision in conventional laparoscopy can be done only with people like Dr. Kunta Becker. So next is artificial intelligence in surgery. That is going to be a big event in coming years, because it can accommodate any number of surgeries as the trial, and they can generate their own database and guide us during surgery. So there are so many videos which can be analyzed by AI, and they develop their own system and they can guide the surgeon in their surgery. Sophisticated data analysis, real-time visualization and robotic precision will help. So AI-driven analysis means it collects all the data from various surgeons being operated, and it has its own 3D reconstruction, and it will guide you during surgery. AR guided visuals means your actual visualization, and it is reconstructed by 3D, and they are all, both are merged, and you will know exactly where is the ureter, where is the problem. In cases of endometriosis, you might have seen it is very difficult to trace the ureter. So if you have guidance, definitely your fear is lost and you can operate many more surgeries. So AI predictive models, they are available, you can use it. Tailored interventions, so you will know exactly where to operate, where to go, where to start your incision, everything is guided by AI. And prognostication, beforehand only you can prognosticate this patient is going to have problem, this patient is going to have good recovery and all. And you can definitely go for case selection, and most important is self-appraisal. Your confidence level also increases. So who is your future teacher? It will be like this. So there is no nurse, there is no assistant, there is no anesthetist, only surgeon. You can do anything you want, and it is guided by AI. So thank you so much.
Thank you, sir. Any questions from the audience? I request Dr. Nitin Shah sir and Tanish suturing skills, tips and tricks.
Another session of ergonomic of suturing. Today morning we saw there were 6 suturing, endopelvic suturing training session, and there were a lot of enthusiasm amongst the candidate to learn the suturing. So learning in right way is very important. So what is ergonomic? The word ergons means meaning at work, and nomos meaning a natural law of arrangement. So ergonomic is a scientific study of the people at work in terms of equipment design, workplace layout and working environment, safety, productivity and training. The ergonomic is based on anatomy, physiology, psychology and engineering combining a system approach. In a simple word, it is a science to make the setting and surrounding favorable for the laparoscopic surgeon. The term was formed way back. What is the importance of ergonomic in setting the laparoscopy? Is basically to reduce the suturing time and reduce the complication or the side effects to the surgeon. There are two components: sensorial ergonomic, which includes manipulation and visualization, improves precision, dexterity and confidence, while physical ergonomic provides comfort to the surgeon. Together, these two elements of ergonomic increase safety, have a better outcome and reduce stress. What is orthron effect? It's commonly referred to as an observer effect. It has been well observed phenomena that any individual who performs the skills better with more caution whenever he has a knowledge that he or she is under observation and assessment. This allows the result to be more positive. It's both humiliating and frustrating to be observed by everyone in the OT when you take more than 15 minutes just to do a square knot. So what are the learning objectives? So the talk is divided into working knowledge of the suturing equipment, ergonomic of suturing, tissue approximation. So practice, practice and practice. Okay, how we started way back 2 decades back, like before going home every day after OPD, we used to practice for 2 hours. At that time we don't have a pelvic trainer, and what we used to do is the RL ka box hota hai, in that we used to put our scope and 2 sides making a puncture and using instrument, and we used to do suturing practice. But now we have a very good equipment available today. You witnessed by J&J, they have a very good equipment of endosuturing. So skills can be really improved at a faster rate. So laparoscopic suturing equipment includes good pair of needle holder, a knot pusher for extracorporeal suturing, a good suture material which don't have memory, like Prolene if you use have a lot of memory and it will be difficult to put a square knot, but if you are using something like a Vicryl or a polygalactin has a better suture material. Definitely camera plays a very important role. Nowadays everybody has switched from to 3-chip camera and now 3D, and a good assistant has a major role to play in any suturing. So one has to invest in a good needle holder. You may have a tungsten carbide or a diamond cutting and a straight or a curved. Maybe you have a 1x2 tooth grasper, whatever suits. One can the tooth grasper can be used as a tissue grasping forceps also. These are the welcome addition where you don't know how to align the needle in a smiley position. There is an auto-aligned self-retaining needle holder which you just lift the needle and it will be getting you in the smiley position automatically because it has a natural curve. So that first picture is of the self-retaining needle holder. Then there is something called an endo stitch. So you just hold the 2 edges of the wall, you just fire, the needle will go from top to bottom, you fire again, needle will go from bottom to top, and it's like sewing machine, and there is an auto suture which is available. So suture material we already discussed what to choose. Coming to ergonomics of suturing, so laparoscopic suturing is a different ball game. If you compare with the open surgery is fast, ergonomically optimal because we have a 3D vision when we do open surgery. Our both eyes are open. When you close one eye, the 3D vision becomes 2D and you have a loss of depth perception. So in laparoscopy, suturing is a slow and steady process. You require repeated practice. The advantage is magnification effect, and the choreographic movement is like a mathematics. When you learn suturing, it is nothing but the mathematics. First step, second step, third step, and then you'll be able to throw the knot. And what are the vitals in the ergonomics? There are few angles which you need to understand, like triangulation and manipulation will be coming shortly in that. Open surgery, high degree of freedom, surgeon works in line with the visual axis. Your visual axis and motor axis are in line. Whereas in laparoscopy, you work this, your visual axis is somewhere else and your motor axis is somewhere. So there is a dissociation of the visual and a motor axis. Kahin pe nigaah hai, kahin pe ishara types, So as I discussed, 2D has no depth perception. There is a in laparoscopic surgery 2D image. There is no depth perception. Loss of tactile sensation in laparoscopy. What we say, there is loss of tactile sensation. But with over a period of time, you start gaining that tactile sensation with the help of your own instrument. So that can also be come up with the experience. And there is a decoupling of the visual and motor axis. 3D has definitely improvised the suturing skill and learning in the laparoscopy because of the depth perception part is taken care of very well. 3D is like actually sitting inside the abdomen and operating. Definitely 4K will add more colors and depth. So now considering the flow, the important consideration in the suturing, first thing is port placement. The right port placement is very, very important so that the triangulation effect of the camera and the port has to be very, very important, and coaxial alignment of the visual field. So there are various principles in ergonomics: the straight line principle, triangulation, manipulation angle, elevation angle, low line table, and gaze down view. So this is a straight line principle where the surgeon is standing on the one side, pathology is in between, and monitor is on the opposite side, so that the surgeon is looking straight to the monitor and don't have to deviate the neck. So this is the straight line principle. Now this coming to the port placement. The port placement, generally what we see is the umbilicus or a supraumbilicus is the camera port. Then there is a arc formation, 2 on the left side, 2 on the right side. So this basically follow the principle of the baseball diamond concept. So this is how you put your scope for the contralateral or an ipsilateral. So that generally forms the arc. So this you follow the arc and you decide your port placement. The first lower port is 2 finger breadth above and medial to ASIS, and the second port is approximately stretch your 2 fingers. Stretch your 2 fingers, which is approximately 10 to 12 centimeters. So once you place your one finger at the lower port, try to stretch, and that is the second mark, which is approximately 10 to 12 centimeter apart. So this forms a nice triangle. This is the apex of the triangle. These two form the base of the triangle. So this helps in the suturing. Suppose if you put 2 port very close, then there will be a parallax of the instrument and you will not be able to make a loop. So these are the ideal angles, manipulative angles. So these are manipulation angles. The correlation is while eating with a chopstick or a fork and knife. So this is how this is the optical axis. This is the angle between the optical axis and the operative instrument. That has to be 60 ideally. The second is azimuth angle, which is the angle between the 2 operative instruments, and this for the contralateral, the optical axis being in the center. So it has to be 30 degree on either side, making it 60 degree. And so finally the elevation angle. So that is from the horizontal plane where the patient lies to the elevation of your instrument. That is also 60 degree. So this is the ideal scenario which will not give you fatigue. Initially when we started our practice, Shailesh Kutambekar sir ko dekhte the subah se raat se is operating, still energetic. And after doing one hysterectomy, one word suturing, this got fatigue. So we understand that what we are doing is something wrong. The ergonomic has to be changed. The table height has to be low. We used to shrug our shoulder and do suturing. And at the end of the one surgery, we used to get fatigue. So that is very, very important. So this view, generally we see monitor is very high and surgeon is operating like this. Then you will have cervical spondylosis soon, the back ache, cervical ache, and whatnot. So this is the ideal position. If your vision monitor should be in the straight line and you should not look up. So that is very, very important. This is the wrong position. Your shoulder is getting stuck, your elbow is also flexed. It has to be relaxed. This is the wrong position. So this is the ideal relaxed position of the laparoscopic surgeon, where straight head in the axis of trunk without rotation or extension of the cervical spine, shoulder in relaxed and neutral position, arm along the side of the body, elbow bent to 70 to 90 degree, forearms in horizontal or straightly descending axis, hand pronated physiological resting position, hand and finger with light grips and handles. And the patient table has to be below the waistline. Gaze down view of the monitor. Straight line principle and all triangulation principle what we study. If this is normal, definitely you can work for the longer hours in a day without any fatigue. So patient position, Trendelenburg position is given. This produces gravitational displacement of the viscera away from the operative site, and that is very important, 50 to 20 degrees, but however there is a risk of the aspiration if patient has a vomiting or something. So today morning only we had a lecture on anesthesia, spinal versus G, again a controversy. But definitely nowadays we do a lot of cases under spinal anesthesia and supramajor under the general anesthesia. And this is the head-up position for gallbladder, where you want viscera out of this Callops triangle, but the blood will get accumulated in the calf muscle and there is a high chance of DVT. So always better to put patient on DVT pump post-operative or supplement with the low molecular weight heparin if the surgery is lasting for more than 3 hours. Coming to the suturing part, either you can do contralateral suturing or an ipsilateral suturing. But contralateral suturing, your arm span has to, you have to go on the opposite side and hold the needle holder. So this arm has to be really long, your height has to be good. If somebody is short-heighted, contralateral suturing will be little bit more difficult. So more fatigue, obstruction to the assistant, because cameraman is always struggling with the camera, you are pushing your telescope down with your arm, so there is always a tug of war between the assistant and an operative surgeon in a contralateral suturing, unless the table is very, very low. Okay, and ipsilateral, more surgeries you can do easily because you are very easily relaxed and you are suturing from one side, from the other side the assistant is showing you all the things. Also the opposite port in the ipsilateral suturing port is free. The opposite surgeon can assist you for holding the thread or retracting the bowel, which is not in the case with the contralateral suturing. So there is a concept of suturing in a vertical zone developed by Professor Charles Coe, which says that the vertical zone refers to the sagittal plane with the needle moves. Like if you are doing contralateral suturing, the needle will travel from top to bottom, and if you are doing an ipsilateral suturing, the needle will travel from below up. So this is nothing but the suturing in a vertical zone. So this is how your movement should be, and this is what is called as a belly of needle holder, the dancing of needle holder, which helps in the doing the suturing thing. So the port position, suturing style and closely choreographed technique all comprises what is called as a laparoscopic suturing in a vertical zone. We are what we repeatedly do. Excellence then is not an act but an habit. Adept and successful laparoscopic suture are made and not born. Now coming to the ergonomic of hand instrument. Everybody knows that conventional laparoscopy only 4 range of movements is there, in and out, circular, and in robotic even the wrist movement is there because of the robotic arm. So that is the advantage. You have a more ergonomics in case of robotic surgery. The length of shaft of the instrument is very, very important. Sometimes in demo unit you get a bariatric instrument for the normal surgery. It becomes very difficult to do it. Why? Because of this fulcrum effect. So this is the fulcrum effect. The length of this is your trocar and this is the abdomen. The length of the instrument outside and inside is very, very important, because this is the fulcrum. If the effort, if your more part of the instrument is inside the abdomen, here 2 centimeter movement, here will be 5 centimeter movement, if the fulcrum is not in the center. So this has to be very, very important. That's why you have to choose your instrument, whether you are doing bariatric, whether you are using bariatric instrument or a normal 35 centimeter instrument. So this you should understand. And then coming to the handle design, by what suits you. And then now coming to intracorporeal suturing, I can recognize a good surgeon not from how he cuts but how he sutures. Okay. So this is the critical steps of suturing, how to introduce the big needle inside the abdomen. Number 1, grasping the needle, tissue penetration and knotting. These are the steps of suturing. So through a 10 mm port, this sometimes for the tuboplasty we use 50-prolene and the needle size is very small, so you cannot drag through the abdomen. So what you do is you pass the needle through the 10 mm, remove the telescope and pass the needle through the 10 mm trocar, so that it goes inside the abdomen very easily. Otherwise what you can do is, this is how you introduce the needle inside the abdomen, remove the lower port, pass the needle holder and then load the thread, and needle is at least 2 centimeter away from that, and this is how you load inside and then just push the trocar inside. This is how you introduce any size of needle inside the abdomen through the 5 mm port. This is the grasping of the needle. This is something called as a sweat point. This is, and so this is the point A. Whenever you are inside the abdomen, hold the suture material with the right hand at A point, which is either 2 to 3 centimeter away from this a junction of the needle and a thread. So you lift the needle in the air. Then with the help of the left hand, you hold this B point, which is at the junction of anterior 1/3 and posterior 2/3. So with the right hand, you hold the thread, you lift the needle is hanging in the abdomen. With the left hand, you hold at the point B, and then finally release this first hand and come to the point C. So this is your final point with the right hand, and the needle is ready to pierce the tissue. So this is how you set the needle inside the abdomen. There is a concept what is called as an active needle and a passive needle. So whenever the needle is loaded on needle holder, that needle has to be under vision throughout, because its active needle is very dangerous. If you move inside the abdomen out of vision, wherever the point touches, you are either creating an injury or you can puncture the major vessel. So this active needle always has to be under vision on the screen. It cannot go out of the screen anytime. Passive needle is when you hold the thread and needle is just hanging. That is passive needle. That is harmless needle. It will not pierce something. Okay. So this is the knot, which is the square knot, which is very, very important in any suturing. These are the steps of hysterectomy. This is the bladder dissection, and here we will be taking the uterine artery. This is the use of harmonic. So this is how you pass the needle, remove the needle, and then try to make a C, nice C. This is square knot. Okay, this is the opposite side. This is how you pass the needle, and this is how you place the square knot. The square knot is very, very important, which is tight and secure. This is a video on a pelvic trainer. Volume. Volume. So this is how you held the needle. Then we have to do a pronation and supination at wrist. This is the suturing in vertical zone. Support the tissue. This is how you make the C, and this is a basic suturing where you use needle as a fulcrum. Okay, and you make a throw and then tie it. So when you use needle as a fulcrum, it's a basic suturing. Now you are using thread as a fulcrum. So this is the advanced suturing. You make a loop, rotate the needle holder so that the shaft and the thread becomes a 90 degree, and then you can just do a rotatory movement and take a loop. Now when you open the needle holder and try to make a loop, then that is the thumbs up technique. So this is the expert knotting where you can view. Now in this case you can see only left hand is rotating and right hand is fixed. Okay. So right hand is acting as a piston and left hand is rotating. So this is the one way. Second way is left hand is fixed and only right hand is rotating. This is how you can plan. And with expert, you can use both hands. You see tomorrow Sailesh Kuntambekar sir or someone who is doing suturing, both the hands will be working. This is a thumbs up technique where you are making a loop. Now what? No good, because you are suturing away from the site of suturing. So that is not a good technique. So you have to stay close to the area of suturing. Like if you are suturing at the wall, stay close to the wall. So this is the right technique. Stay close to the area of suturing, take a loop there and there only, and you make a knot there. Now you never hold the thread in the center, you will get a loop. Okay. So you always hold the tip of the end of the suture so that you can take a proper square knot. So these are small tips and tricks in suturing which will definitely improve your skills. This video is there on YouTube, my channel, you can go and see again. Now coming to the advancement in the suture, I hope everybody has started using the barb suture. Nowadays people are using even for the cesarean section. So this barb suture is really a watertight sutures, and there is a uniform tension throughout the length. Okay, there is because you just keep on. It's like a big bazaar ka block, one way. Once you pull, the barbs open up and it will stay inside the tissue, and the suture cannot be loosened after that. So pulling is very, very important. I have seen people just taking 1, 2, 3. No, after pulling out, you push and pull the thread out. Wait for few seconds. Let the barb open up. Get it anchored to the tissue. Only then it will stay there. Otherwise, the barb suture is not tightened, then it will not act properly. This is a very old video. This little part. So this is baseball suturing, what you can see. Okay. See, I am pulling it and just pressing it hard so that you can pull the barb will open. Just few more seconds. So this is the barb suture. People are awake. This is the extracorporeal suturing, not extracorporeal, basically intracorporeal suturing with the help of the Rhodes knot. So this is the Rhodes knot used for appendix. In Gynae, very less application. Initially, people used to tie the hydrosalping base using this technique and remove the hydrosalping. But nowadays, we have a better electrosurgical unit, so we don't require to tie. This is the extracorporeal suturing also we don't use. Staplers in this is the case of a incisional hernia. So you can see this is how the suture passer or a port closure needle is used, and you take 3 or 4 sutures. These are non-absorbable sutures. This is to close the defect, umbilical hernia defect. Then from the skin, you use port closure needle and try to get both the ends in the center using this needle, and then you tie so that internal ring will get collapsed, and then you can place a dual mesh. So this is how the defect is closed, and then the dual mesh is applied, and the mesh is fixed with the help of the tacker. These are disposable tackers. Okay, so physical constraint to surgeon due to inefficient application of ergonomic to the cervical spondylosis, shoulder pain, which is called as a chicken wing shoulder for the oral laparoscopic shoulder, backache, hand finger joint, tenosynovitis, burning eyes, stress exhaustion, hand muscle injuries. These are very common in laparoscopic surgeons if the ergonomic principles are not followed. It is not practice that makes perfect. It is the perfect practice that makes things perfect. The final video. This is what happens if you go inside the OT without preparation. This you enter without practice. Okay, see the broken myoma. Practice makes man perfect. Thank you very much for your kind attention.
Step forward in the management. Over to you, sir.
At the outset, I take this opportunity to thank Prabha and her team, Gadag Society and IIG to give me the opportunity to speak on this important topic of endometriosis, how to rationalize the treatment for our patients. So nowadays we have a lot of discussions about endometriosis. Is the incidence of endometriosis increasing, or are we understanding it better? And understanding the treatment, the diagnosis and the management better. So I will be speaking on deep endometriosis. Deep endometriosis is not a cancer, but it behaves like a cancer because it penetrates the nearby tissues. When the penetration is more than 5 millimeters, it is deep endometriosis. There are various postulated theories, out of which these are the possible reasons why it happens. So why it is important to address a deep endometriosis which is in the pelvis? Because it is likely to invade and cause damage to the vital organs. So the vital organs around the uterus, bowel, bladder, ureters, pelvic nerves which control the bladder, bowel and the sexual function. And then we have rare sites like thoracic pleural endometriosis, umbilical endometriosis, sciatic nerve endometriosis and urinary canal endometriosis also. So endometriosis is associated with a lot of misconceptions. So it is rare for the disease to occur in young teenagers. No, it's not like that. You can get it at as early as 18-20 years. It can be managed medically by medical treatment. When the patient of endometriosis goes for a fertility treatment, when the patient is having pain and symptom, it is not addressed to. So, is fertility important for you at present, or pain is not the proper way to address? The pain has to be addressed. Ablation of endometriosis is the treatment, or no, it is wrong, it is the excision. The young patient should not undergo surgery, they should be put on medical management. So it is also a misconception that the young patient with deep endometriosis, we don't operate, we put them on long medical treatment, and which make the vital organs at risk and make the subsequent surgery more difficult. The problems with endometriosis, what we generally face is delay in diagnosis, incomplete multiple surgeries and the recurrence. The symptoms which we should specifically ask our patients is pelvic pain, dysmenorrhea, pain when the period is not there, change in the bowel or bladder habits during the periods, radiating pain to the legs, dysphagia, dysuria. Whenever you have a posterior compartment or IHP involvement, you may have a patient complaining of dysuria, urinary symptoms, and then deep dyspareunia. You should chart in a visual analog scale, diagnosis by the detailed history and the clinical exam. You can see a vaginal nodule. Most important investigations here would be a transvaginal sonography by a person who is used to doing a mapping for endometriosis or used to seeing endometriosis in the pelvis. So the central compartment, the lateral compartment are very well assessed by the transvaginal sonography. So as a clinician, we should actually train ourselves to do the transvaginal sonography ourselves and diagnose the endometriosis, the deep endometriosis lesions. Then MRI for the patient. Ours is a multidisciplinary team center in Mumbai, so where patients will come from outside. So it is convenient for us to do MRI and then assess the MRI before the patient, you see the patient, or when the patient is an unmarried patient, you can't do a transvaginal sonography. MRI gives you a very good idea about the extent of the disease. It gives you how to plan the surgery also. So you can see a hypoechoic nodule on the back of the uterus, which is the deep endometriotic implant. You can see a large thickening of the bowel wall. So whenever there is a bowel involvement, we see the hypoechoic nodule and the thickening in the bowel wall. So how does it go to the nearby organs? So whenever there is a posterior wall adenosis, it can go in the upper rectum, the toric disease can go in the middle rectum, the vaginal nodule will go in the lower rectum. So this is the part of the rectum which can be affected. The bladder, the cervical disease, the lower anterior can go in the trigone, which may require reimplantation. The upper fundal disease can go in the fundus of the bladder. Again, the adnexa, right adnexa can be have a penetration into the ileocecal junction and left hand is in the sigmoid column. Whenever you have endometriosis in the uterosacral ligament, you may have pull on the sacral nerve roots and you have sciatica like radiating pains which can direct us that she has a deep endometriosis in the deeper parts of the parameter. So we should have a multidisciplinary team approach. Primarily, gynecologist who is trained in the excisional endometriosis surgery and four specialties: the colorectal surgeons, the urologists, the plastic surgeons, and the thoracic surgeons. As and when required, the team is formulated for the particular case. This is the spectrum of the disease. So, if we have a deep endometriosis on evidence on MRI, should we put them on a medical treatment? So, by various studies and what we follow in our center, the deep endometriosis which is evident on MRI, primarily we put them for excisional surgery. The medical treatment generally is used to prevent the recurrence and to protect the fertility potential. So, when the patient wants to have a pregnancy, she can have a pregnancy. More likely the ovarian disease and the adenomyosis may require a long-term medical treatment so that it doesn't recur after the surgery. Whether we should do an ablation or an excision. So the ablation is not the thing. You should do an excision of the implants. The recurrence rates after excisional surgery are the minimum. So all the studies guide to that. So whenever we have a deep endometriosis patient, we have to see this particular compartments, the peritoneum, ovary and the tube. We follow this hashtag Enzians classification. The MRI Enzians is compared with the surgical Enzians. So peritoneum, ovary and the tube, the central rectovaginal septum, parametra and the rectum itself. So surgical treatment of endometriosis can be definitive or a conservative treatment. Conservative treatment when the patient wants to conserve the uterus, tubes and ovaries for the fertility. So whenever we see a deep endometriosis lesion on the back of the uterus, we excise we do a butterfly peritoneectomy. In these steps, what we follow is we dissect the ureters, we dissect the hypogastric nerve and the bowel. When all these structures are separated, then we excise the peritoneum and do affected peritoneum has to be excised so that the recurrence is very less. So this is a large nodule and the complete excision of the endometriosis. And you can see the ureters, the hypogastric nerve, the ureter, hypogastric nerve and the rectum separated. Coming to bladder endometriosis, when you have a bladder endometriosis, by cystoscopy we assess the lesion and the distance from the ureteric orifices. So if the ureteric orifices are very close, we will do a stenting, and when we see the lesion, we mark the lesion with the receptoscope from down if it is very near, and then we do laparoscopy, open the medial pararectal space medial to the operative umbilical artery, and mobilize the bladder to go in the the vesicovaginal space below the nodule and isolate the bladder nodule. So the surgery is isolation of the nodule and excision. So whenever we isolate the bladder nodule, mobilize the bladder completely from the uterus, then we fill the bladder with the saline, and the bladder is open at the upper margin of the nodule. So this is the medial paravesical space, medial to the operative umbilical artery. We saw from the beautiful video of various species. So all this knowledge of retroperitoneal anatomy helps us to do this complex case. So this is the upper margin of the nodule. We open the bladder and excise the nodule. Suture the bladder in two layers with generally 2-0 or 3-0 wheel of sutures. Coming to the lateral parameter, you can have a lateral parameter nodule sitting on the uterosacral ligament, or you can have a lateral parameter nodule on the uterine artery. So whenever you have a parameter nodule sitting on the ureter, you can split the nodule, one part on the uterosacral, one part on the uterine artery, and remove it. And then this is the ureteric involvement, the frozen pelvis. So mobilization, development of spaces, identification of the ureter, identification of the iliac tree. This is a large ureter, you can see. Generally the compression is at the level where the uterine artery. So this is the uterine artery at the origin. So you develop a iliac tree laterally. Take the uterine artery at the origin and then inverse the uterine artery and release the ureter. All the endometriotic sheath around the ureter has to be excised meticulously. So we prefer stenting in such cases. The surgery is, the stenting is preceded by before the ureterolysis. So in this case we have already put a stent and now we are excising all the endometriotic tissue over the ureter. And there is always a sheath which has to be, which is circumferential. And we have to excise it. The ureteric endometriosis is a silent disease and it may damage the kidneys. They will just come with backache and ovarian cyst or a deep endometriosis in the pelvis. So whenever we have a deep endometriosis pelvis, always important that we scan the kidneys and you can see the constriction in the ureter and the release. Generally these stents are removed after 4 weeks and then they do very well after surgery. Very rarely for such cases a reimplantation is required. So meticulous dissection and excision generally works. Coming to the bowel endometriosis, the bowel endometriosis basically when we have involvement, it's not very uncommon to have a bowel involvement. Most common affected area is the rectum. So the investigation, I would require few important understanding. What is the length of the nodule? What is the number of your nodules? What is the length of affection? How much distance from the anal verge? How much is the circumference? So how much is the circumference and how much is the thickness? So whenever there are 2 surgeries on bowel, it could be conservative surgery, which is superficial shaving, and the second is deep shaving till the mucosa, or disc excision, and radical surgeries are segmental bowel resections. Conservative surgeries have a less complication rate and less chances of having constipation post-operatively. So these are the common steps which we follow for endometriosis, bowel endometriosis. First we mobilize the sigmoid, then we identify the ureter, then we go and develop the pararectal space, identify the hypogastric nerve and go retrorectal above the nerve plane. So nerve plane is identified first and above the nerve plane we go in the pararectal space. Once we identify the hypogastric nerve, preserve the inferior hypogastric plexus, then we develop some retrorectal space. After that, we have to drop the bowel from the back of the uterus. So going close to the bowel fat on medial pararectal space on both the sides, and at the end dividing the nodule in the center, half nodule going on the bladder bowel and half nodule going on the torus to reach the rectovaginal space below the nodule. So these steps are followed to isolate the bowel nodule. So any surgery on bowel, first step, common step is the isolation of the nodule. First the nodule is isolated, then it is decided whether you are going to do a shaving, a deep shaving, a disc resection, or this patient is going for a colorectal resection. So this is a video, small video which shows the common steps. So you mobilize the sigmoid, then do the ovarian fixation for exposure, go in the pararectal space, identify the ureter, identify the hypogastric nerve. So this is the hypogastric nerve. So you go one plane above the hypogastric nerve in the retrorectal space and go. This is the retrorectal space above the nerve plane, and then you assess the nodule. Then you come medial to the uterosacral ligament on both the sides and drop the nodule from the torus. So these are the steps common for any bowel surgery. These are the steps taken for isolating the bowel nodule. Once you isolate the nodule, then we think what to do, whether we are going to do a shaving depending on the involvement. So then coming for the bowel shaving, first again the isolation of the nodule, then we remove the surrounding fat, expose the serosa, and then go for shaving. This is a short video which will demonstrate the procedure. So this is the bowel nodule laterally, the right lateral uterosacral ligament has involved the bowel wall. So we just remove all the fat from surrounding areas. Expose the bowel serosa from all the sides, all around, and then start digging inside the muscle of the muscle. Till the time you see the healthy muscular fibers, and then take the reinforcing sutures and do the bowel testing. So this is the final picture after removing complete nodule. What if the lumen opens during shaving? Opening the lumen during the bowel shaving is not a complication. Basically, it is a disc excision. So we suture the bowel in 2 layers. We can suture with 3-0. We generally use 3-0 Vicary or 3-0 bark suture. In this particular video, the bowel has opened. If the opening is not very long, less than 3 centimeters, it is always better to suture transversely in 2 layers. But if the length is very long and the circumference is less, than around 20% to 30%, then they can go for a long shaving and a vertical suturing. So there has been many teams which follow this disc resection where the bowel nodule is isolated, then end-to-end anastomosis stapler is passed through the rectum, and the bowel nodule is invaginated, and the anterior wall of the rectum is stapled and the nodule is removed. So this particular video is demonstrating that after we isolate the bowel nodule. We take a stitch from the upper and the lower margin of the bowel involvement, put the end-to-end anastomosis stapler from the rectum, and at the lower margin of the weight at the lower margin of the nodule, open the stapler, and the stitch pull will invaginate only the anterior margin, anterior wall, and the stapler is antiverted, so that only the anterior wall can come inside, and you have a staple line which is only in the anterior wall, and you can remove the disease which is there. So this is the other way we can do the disc excision. What about the sigmoid lesion? Sigmoid doesn't tolerate shaving as good as rectum, so always and most often sigmoid lesions are stenotic. They generally go for resection, and they may present with obstruction also. Coming to the resection, again the steps are same. We isolate the bowel nodule, denude the fat below, applying the lower edge, divide the bowel below the nodule. Manila incision, you can take the bowel wall out and place the anvil and anastomose inside. So this particular video, this is a large occlusal nodule on the bowel. So then we isolate. So this is a nodule which is isolated. Below that, we divide the bowel. Take a manila incision. The diseased part is excised. The anvil is placed. and then it is anastomose. So for our occlusive nodule, this comes as a better option. You can do it as a nose technique in which you don't open the mini laparotomy. Short of time, I will not show the complete video. So we open the bowel in top. We require a very good bowel preparation for it. We do a then the specimen can be removed from the rectum or from the vagina if it is open. And then, so this avoids the mini laparotomy, provided the bowel preparation is good. We generally do this technique. So our center is a deep endometriosis management center, but our resection rates are very low. 95% of deep endometriosis nodules are feasible for shaving technique. Shaving exposes patients to low risk and rates of complications. Shaving and rectal resections are comparable in terms of recurrence rates. The first line shaving could be tried. Resection should be reserved for stenotic lesions, sigmoid lesions, multiple nodules, and where the bowel wall thickening is too much, with more than around 8-9 millimeters, because it has less complication rate. The secret of best result in endometrial surgery is to tailor your surgery for your patient, respect the patient's requirements, multidisciplinary deal, the 3D vision. We should be radical towards the disease and conservative towards the function. We all thank Sir every day for teaching us retroperitoneal dissection, for which very important to do endometriosis surgery is knowing the retroperitoneal anatomy. If you know your spaces well, then only you can attempt this complex surgery. Yes, there is always a benefit of having a 3D vision. You can generally never do these cases in 2D. We take a 3D vision and good energy sources.
Thank you very much, sir, for the excellent presentation.
Last lecture also, and I thought that Prabha has told me to present one of some bad work done by me and lessons learned by me over the last 20 years of laparoscopy. So this is about the complications. Yeah. Life is a series of complications, and it is very important for us to deal. So this is a book which is written by Atul Gawande. Complications do occur with everybody. Complications only do not occur with the surgeons who do not operate. So don't practice until you get it right. Practice till you can't get it wrong. And practice makes you perfect is the wrong thing. Practice makes you perfect in the things that you practice daily. So if you are doing wrong things daily, you become perfect in the wrong things daily. That is the most important thing. So accidents may happen. Can you put the volume? Volume is...
Sound.
Yeah. So you see the video.
Sir, in your laptop.
No, there is an audio problem, but anyway, just see the images which can take place. See the best drivers, the best people, still in a racing car, everything can go wrong. So this is how what can happen. You can see a very good sky driver coming there and then getting engulfed. So the best people in the world can also face problems, but what is more important is the spirit to get back to work. So we as surgeons do face complications. We go 10 years back in our practice, but still we will come back, and we will come back in various situations. So anticipate the problems. Anticipation is the key. And the reasons for complication is because of novice surgeons, lack of knowledge of anatomy, and lack of instrumentation. I'm not going to go into the entry related complications because this is not very important. None of the patients die with the Verni's needle. You should always use it in the palmer's point, and then these are the basic things which I'm not going to go into. But what is more important is the first trocar entry. If you don't do it, if you do it in the head down position, this is very, very bad, because if you keep it in a flat position, the distance between the abdominal wall and the aorta is much higher than when it is in the lower part. Now what is this evidence? If you are in trouble, always use the visual entry. This is a visual entry. We always teach our residents the visual entry, how to go ahead and do this, and this is how you can enter the entire thing. Very, very minimal facial damage. This is very, very basic. This is with the optical trocars that you get, and you can do it. And even then, you can get this injury. You see the optical trocar? The optical trocar has gone into the small intestine. Nothing is seen. You feel everything is okay because the bile is not leaking. But as you dissect this area, you will find that there is a small intestinal injury which has taken place. So ladies and gentlemen, don't be 100% sure that you have used the optical trocar and nothing will happen. You can see the injury there, so it can still happen, and therefore it has to be, you have to be very, very careful. You can see the site of injury very clearly. What about the vascular and bowel complications? They can happen. I have already shown you what are the various things which you can put through the scope, and inferior epigastric vessel is the commonest thing. But understanding the anatomy is important. There are no branches to this vessels. So whenever there is in trouble, why I am showing this video again is because you are going to see some vascular complications which are few ghastly and which are not. This is the entire area. I have shown you this slide. There are no arteries, no tributaries over there. So look at the vascular complications. There are two, arterial and venous. And the risk factors are inexperience of the surgeon, or callous attitude, or extreme amount of high confidence which can happen. What are the steps to be done? We will see as we go ahead. What are the possible sites? Anything can go wrong and anywhere can go wrong. And this is the management, but we will now see this. This is the first complication that we ever had, and this is an anterior exentration that I was doing. Look at the old film. This is a long, this is the harmonic which we had. Now in anterior exentration, we take the internal iliac artery. So we are dissecting the internal iliac artery. The first thing is extremely badly used instrumentation. Nobody uses a needle holder to go there and take this. You should have used a Maryland. I am trying to take the Vicryl to show off that I can tie the internal iliac artery, not realizing that there is bleeding taking place at the lower part. I am still grappling, trying to take it, and boom, the artery goes off. And this, in the next 5 minutes, we have specifically unedited all the bad words that were said in the theatre. The assistants were always at the fault. The technician had the guts to record this video, which is the most important thing, because it didn't stop even though I was cursing everybody. The suction didn't work. The suction was sucking something which it should never suck. See, it is sucking the entire tube and the ovary and not the blood, which is always the common problem. But look at the left hand, and this is a completely unedited video. I had already separated. Then somebody suggested, let's put some water, making things more complicated, because you don't realize what is blood and what is water. More and more and more, and everybody, there are 20 people suddenly alert in the theatre trying to give you all instructions. But suddenly I realized that I had my hand there, and then with a big ligature, this ligature no longer exists in the country and anywhere in the world, 10 mm ligature, it was called as the Atlas, and then I could catch hold of the internal because it was there, and we could clamp the internal iliac artery and we could stop the bleeding. Total time taken was less than a minute. Anesthetist was brave enough to tell us, continue with it, and don't worry, if the BP falls below 60, then I will tell you. And that was the reason we continued. Now the bleeding is in control. Now I put more and more clips till the patient goes into titanium poisoning. It is not needed. Absolutely. And then you can realize that the tie was already there. All I needed was to tie this, but no presence of mind, and therefore this has happened. So the conclusion of this, wrong instrumentation, wrong presence of mind, and now you see more clips coming in. Till the entire clip applicator is full of this thing, but the bleeding is already stopped. This is unnecessary. So this is what happened. Then similarly, a long video, you can see a very, very old video, and all these complications are mine, not borrowed from anybody. Please, because a lot of time people say, my friend has given me this video. No. Now there is a bleeding which is taking place. Now this kind of bleeding is always there from small tributaries. Don't worry about it. This will always stop. What would you have done when you did open surgery? You would have put a gauze piece and then stop. Venous bleeding stopped. So I put a gauze piece, took out the entire nodes, completed the procedure, and the gauze has done its job. The bleeding has already stopped. So not every bleeding needs to be controlled. What about venous injury? Now this is something post-radiated, very after doing something like 300, 400 radical hysterectomy, we suddenly became overconfident and started doing surgeries where radiation was given. And you can see while doing this, there is an injury to the external iliac vein. Now we know that there are no tributaries. Why anatomy is important? So what did we do? We healed it with both the sides because we know that there are no tributaries. And then with this, we just stop the bleeding. We put an additional port, stop the bleeding for the time being. The bleeding stops after pressure, but don't worry. If you don't do closure of this, then after 48 hours you will get more bleeding. That's where in the era of barb suture, suturing skills are equally important. So we used a 4-0-proline. Normally these materials are available in the surgeon's theatres, but we could immediately suture it and we can control it. The moral of the story is art of suturing is always important and everybody should know. Even barb suture is something which you cannot use on the vascular side. We can control this bleeding. Now there was another injury which took place, and look at this. This is again a post-radiated patient. This was not done by me, this was done by one of my consultants. He wanted to do this, and you see now there is a bleeding again from the external iliac vein. Now in this situation it is very close to the bifurcation, so we cannot clip it. So I use again a 4-0-proline from there and we could suture it. Important thing is when you use a 4-0-proline, not to pick it up very heavily, otherwise the tear will extend. So this is an injury. The biggest problem with these injuries is not tackling the bleeding, but the problem is that you may get CO2 embolism because there is a big tear in the vein, and that you have to tell your anesthetist to look at the blood pressure as well as the pulse and the ET CO2. If the ET CO2 starts falling, end-tidal CO2C, this bleeding is very dangerous, not from killing the patient but because of CO2 embolism. So we have taken a figure of 8 suture and then finally we could suture it. Now this is what is another attempt to show heroism. This is a big node which is stuck to this the entire external iliac vein. Knowing the anatomy that this is stuck, and this was done in a workshop. So this is where the audience is clapping, take it out, take it out. You know, you tell the wrestler, give one more fight, doesn't matter, knock him out, knock him out. So we also get excited, we try to do it more and more. Okay, I'll take it out. And then there is a tear. Now everybody is watching. Now what to do? Can you suture this? The node is still existing, but we know by anatomy that there is no tributary to this. So temporarily these clips are used. Look at this. We have used the multiple clips over there, and these clips will temporarily stop the bleeding. Doesn't hamper the blood supply of the entire thing. The most important thing is to make the space, because if you don't make the space, then you will not be able to suture the vein. So we put the clips, clamp partially the vein. We can also use the Satinsky clamp, but that is always not available in the where we do these kind of surgeries in a workshop. And then I removed the node in totality. This was in a live workshop in Delhi. Please understand that not many instrumentations are available in live workshop. But then everybody said, now it's okay, don't do anything. But that would be a mistake. The clips will come out the moment the patient starts moving his limbs, and therefore then we sutured this with a 4-0-proline and then took out the clips. It was easy because once this is under control, then you can take this out, suture this and take out the clips. But sometimes things are very difficult. Now internal iliac vein is something as a gynecologist all of us fear. See, because the tear keeps on extending. Because when you try to do this, there is more and more tear which will take place. We are never worried about the external iliac vein which is on the surface. But there is a direct drainage from the presacral veins. The first principle of open surgery, pack, pack, pack. First pack, pack it, one more pack it for some times, pack it till it stops bleeding for the time being. It gives you time to think, you get your energies back, then tell your other people who are in the theatre, including the anesthetist and ward boy, to shut up and not tell you how to handle the situation, because they will keep on telling you where to put the stitch, what to do. After 5 minutes, you will find that there is a bleeding is little bit under control, but again you are not seeing the lumen. What would you do here? I suggest, because artery is seen, then you can see that there is an obturator nerve. Using a bipolar will temporarily stop this, but this is not the correct way to do it, because this is going to open again, because this is just by and now you just take a 2-0 or 1-0 vicryl and put a big stitch under it. Doesn't matter. Internal iliac vein and artery can be easily sacrificed, so you can take a figure of 8 suture, and that's the end of the story. You see, this is done because this is how you stop the bleeding, and this is how you can completely control the bleeding on this side by taking a very big suture. Don't try to take 3-0 or 4-0 proline. This is how you can suture it, like, because you are seeing the internal iliac artery, you are seeing the obturator nerve, vein doesn't matter, you can take a big suture. That's the only way to prevent the further bleeding from this side. But this is one more thing. I was doing a para-aortic surgery, and you can see that there is a bleeding which is coming from the left renal vein, because there was a node which was stuck there. So initially we caught hold of this, because your ego is high, you feel, oh wow, I can tackle any kind of injury. So I am trying to tackle this by holding it. It is still sucking and waiting for the suture to come. But the moment I take out the suction, I still try to hold it and look at the bleeding. Still trying to control it. This is the biggest ego problem of the surgeon. Still trying to control it. Till the time the anesthetist tells shut up and open the patient, and we opened the patient, we could suture the entire left renal vein, the kidney was not lost, and we could completely take care of this. The patient survived, but this is something where you should have opened early, and this is something which you have to understand and do. Now, this is another patient of para-aortic dissection. So we all get this para-aortic dissection post-chemo, post-radiation. Look at the entire video. You can see that at this present juncture, there is some bleeding which is taking place. So we tackle this. You see a lumen, you say, oh, this is gonadal. Don't worry. We will just put a clip. So I have put the vascular clip there, thinking this is a direct gonadal vessel which is there, and I am taking out the node in totality. You can see the bleeding from the distal end of this area. I still put a clip, not understanding the anatomy, and still put a clip, take out the node. Now I feel, wow, I've done a great job, everything cleared. You can see the inferior mesenteric artery. Let's try and find out where is the gonadal artery. And the gonadal artery is fortunately completely intact. And what we have ligated is the renal artery. Now, ladies and gentlemen, what is the situation? The patient either loses the kidney, that's the renal vein down, that's the artery which you can see, and we have already clamped it, there is a gap there, and then everybody is looking at you, that's the gonadal artery. So what we did was, we said, I called the vascular surgeon, he said, I will open, but we may have to transplant the kidney lower down because we have to take it out and again re-anastomose this. I said, let me try it. So we took out the clips from there, and then we said, now, you can see the renal artery pulsating. So I took out the clip. This taking out the clips is the worst part when you put this vascular clip. They don't come out easily. But with the scissors, we took out the clips. Look at the entire video. This is a split-second decisions that we have to take. This is the artery which is pulsating. I used the heparin inside to take out a little bit of clot which was there. These are the two ends of artery. The artery goes into the spasm, and then with the 5-O-proline, I did an end-to-end anastomosis, and this is how we could salvage the kidney. So this was done, and this is something which is we are not proud about it, that this we have done, but I am trying to show you what we can do and what we achieve. This shouldn't have happened at all, but we did it and we sutured it completely. The vascular surgeon was with his gloves in his hands, was ready to open the abdomen at any moment of time and was calling me crazy, but I still did the crazier job and I finished it and the patient's kidney survived. So prevention is the key factor, and this is the vessel knowledge. Surgery without the knowledge of anatomy is like sailing. The idea of presenting complications says that we have learned our lessons. You should also learn your lessons So whenever in doubt, clip the uterine artery. Whenever you find that there is a difficult case, go and clip the uterine artery, dissect the retroperitoneum, see the ureter, and these dissection methods should be known to you so that you can do this. You can clip the uterine artery in bad situations like this, when the patient has like this Vivek just showed you, when you have a stage 4 endometriosis. First go for the uterine artery and then everything will be easier for you. What about the ureter? There are multiple ureter injuries. See, this is my colleague who is doing a total laparoscopic hysterectomy. Everything looks good. Hysterectomy is done. But you know, at this next to the ligature, I see a small lumen. If you can see next lateral to this, a small lumen. I was standing inside the theatre. Everything is perfect and they are saying it is nothing but the uterine artery. But the uterine artery doesn't have a star-shaped lumen. Can you see that it's a star-shaped lumen? Star-shaped lumen is ureter. Whenever it is there, so we trace the ureter from the beginning. And then when this lady was tracing, she is our consultant now, she was tracing the ureter, she traced the ureter, she kept on showing me the peristalsis. See sir, you are getting unnecessary hyper, the ureter is peristalsing, everything is looking good. I said no, go ahead, just go ahead. The ureter, that's the uterine artery, that is the ureter is showing good peristalsis. We kept on doing and digging, she was not ready to accept it. But still, this is the artery, she kept on dissecting this, and you will see that just when we were about, so this is the artery which is going, she said, see, this is the ureter going down. Though I said, just open above the ureter, just use a Maryland forceps above the ureter. And when she was opening this, still the ureter looked good. Nobody in the operation theatre is convinced, but I am not convinced that till we see the end of the ureter. So we kept on digging this, and as we were digging, you will see how it happens. This is how she tried to do this, and then this is a small vessel which is here. So then, as we took the uterine, you now see the urine coming. That's it. So finally, you see that's the urine now coming, and now she believed that it is the urine coming. So it took half an hour for her to convince. Then it is of course very easy. This is the ureteric injury which can happen when there is a tumor. This was a soft tissue sarcoma, which was leiomyosarcoma, which was attached over there. And this injury was a very simple injury. So what we did was, we just did a cystoscopy, and then this injury we passed a guide wire. Look at the guide wire. We don't have to have a urologist. The guide wire was passed with the use, instead of using a SIA, we used the laparoscope to pass this guide wire on the top. Over and above, we passed the stent on this because this was completely seen. Then we sutured this. This stent is already in the place. We sutured the ureter, which is very simple then. And once we sutured the ureter, this is how there is going to be a little bit stricture. So what we did was, we wrapped the omentum around this so that there is a good vascularity which can take place. This is what can happen. And then of course I will show you, this is another ureter. See, it is dilated, there is a stricture. This is an endometriosis, 5 times operated, then referred to us, and you realize that nothing can be done, the stent cannot go, and then this patient had a complete stricture over there. So it is then simple, we take a decision, cut the ureter. This ureter we cut it, pass the stent from lower down, and then we can do an end-to-end anastomosis, removing the stricture. Every time you don't have to do an implantation. You can do removing the stricture at that point was good enough, and we did an end-to-end anastomosis, which was very easy to do this, and this is very simple to do it with a 40 or 50 Vicryl. So you can see, this is what we have published. All of you should start wrapping the ureter with the omentum, because the blood supply gets good, and this wrapping of the omentum is our publication. This prevents a denuded ureter also getting its own blood supply. This we realized when we started doing the transplant. So case, this is, I am not going to show you this. And then of course, this is a patient who presented to us as vesicovaginal fistula 7 days after the surgery. And then we had to go inside again, and then we had to find out that there was a ureteric injury. So everything looks very stuck. We tried to see everything is, because the urine is leaking inside. There is a chemical peritonitis which has taken place. So here, then you dissect the bladder. This is where you dissect the bladder in the anterior compartment. bring the bladder down. Very simple. You can bring the bladder down, then hitch it up. This is the bladder, and there you can see both the stents over there. And this is how you could do this and complete the entire procedure, because the stents were not going, and then we could completely suture the bladder. And this is with the psoas hitch that we could do. This is a patient in whom we had a ureterovaginal fistula. This is the ureter which is completely gone. You can see the ureter completely gone. That's because of the way a lot of energy sources being used. The guide wire is going into the abdominal cavity. So you now dissect the proximal ureter. You have to completely dissect the proximal ureter. This is the infundibulopelvic ligament. Dissect the proximal ureter. Then bring down the bladder over here. Once this is done, then hitch up the bladder to the psoas muscle. So you can hitch up the bladder to the psoas muscle. World's first ureteroneocystostomy with psoas hitch was done by us, published in 2007 in JMIC journal. And this is the first ureteroneocystostomy that we did. Same thing that the urologists do, and this is like implanting the ureter very simply. So this is all the areas where you can go. Bladder injury, very simple. Look at this, nothing seems to be going wrong. We are dissecting the ureteric tunnel. We are dissecting in a wrong plane. This is the ureteric tunnel that we are dissecting. And then we don't realize that at this point, we have already opened the bladder. The anesthetist told us, because he realized that there is a air inside the urobag. So this is a small opening which is there. That small opening could have been easily missed if the anesthetist had not told us that there is air in the back, and then we realized that that was the air which was coming from there. Then of course it is very simple. Just suture this with a tuo, because bladder is the surgeon friendly organ. Then we had very bad, this is something which should never happen to anybody. This is something which happened, and this was a doctor herself, very badly stuck node to the obturator. She had already received multiple chemos and radiation. You can see the nodes very badly stuck, and that was her only option which was there. So you can see that there is an injury. You can see the obturator nerve being cut. This was cut. And now what to do? Again the same principle. Panic reaction is the first thing. First you take out all the node. First you don't realize, just don't stop. Lot of people, when they get just 1 minute more, you can see this is the entire nerve which is completely injured, and once this nerve is completely injured, you take out all the nodes. This is again the principle. Then clear all the node. This is the node which was stuck, and you can see now the obturator nerve. This again we call the plastic surgeon. He said we'll open and do suturing with 7-O-proline. I said why don't we do it with laparoscopy? We did this with 7-O-proline. The patient had adductor weakness for a few days, but 3 months down the line, the patient is perfectly alright. We use the 7-O-proline, which is very difficult to handle, but we could do that, and we can suture the nerve back again. So prevention is the best option. All these is very important. Always do a double-day stenting in difficult cases. This is very important. Or you can use illuminated stents, which you can use, and of course you can do omental wrapping. I'm not going to show you. This was our first publication in 2007. I will just take you to the bowel injuries in a small thing. We have large bowel injuries which you can see, and these large bowel injuries are very difficult. Oops. So this is a bowel injury which was because of the drain which went inside the bowel, and this bowel injury was recognized, and then we sutured it. So big bowel injury, whenever you have more than 5 centimeter injury, not like 3 or 4 centimeter, you can suture it back, but always cover it with the ileostomy. This is the take-home message that you should take away. You can suture this, but cover it with this. Again, in a rectal injury, if there is a small rectal injury, in that case also suture it if it is less than, and the bowel insufflation test is the best way. Vivek also showed you. See if there is any puncture, and if there is no puncture, then do that. And of course, you can do an ileostomy. How to prevent anticipation, and of course during surgery, post-operative healing, this is very important. Adhesolysis, this is very clear. I will not show you all this, and various other things. So you can use the deposit, which of course the rectal shaving can be done with just with this, and roll of ICG. We always use the ICG to find out the viability of the bowel after bowel resection, and we will find it is better. And work our anatomy. And finally, good surgical decisions come with experience, and experience comes with complications. So I'll just tell you that we have graded the surgeons into 4 grades. Grade 1 surgeons are very intelligent and very lazy. You know what they do? They write books. They are very lazy. Very intelligent, very enthusiastic are the best surgeons. The 3rd category surgeons are dumb and docile. They are dumb, but they are also docile. They don't want to do anything. But the 4th category is getting more and more in India, dumb and enthusiastic. And that is the problem with the complications. So just prevent yourself from being grade 4 surgeon. That is not good to do. So this is the grading of the surgeon. You can see grade 1, grade 2, grade 3 and of course grade 4. And this is the danger to the society. See one, do one. Don't get excited when I do a radical tomorrow. Don't start doing it the next day. Learn it in stepwise and you will be able to do this. So take home message. You have to need to change the mindsets. These bad things that we show should come always from the experts. If Karan Johar show says that the film has flopped, you will listen. But if a C-grade producer says why his film has flopped, nobody is going to listen. So idea of presenting complications is, these are my complications. I have learned it over the period of life. You as youngsters should not repeat the same problem. Know your limitations, know your anatomy, and always talk about this. So thank you very much, and thank you Prabha. It has been a wonderful thing again. Thank you so much. All the bad work.
No, I just want to compliment Dr. Prabha. Thank you for that. Sir,